Yes, we can see you.
Yes. I'll introduce myself and then I'll turn it back off just because the lighting's not great. Well, hi, yes, I'm Steph. I'm one of the transplant coordinators and I work with Zdenka and the team at Newcastle. We do all the pre-transplant stuff. So there's 7 people in my team and a few of you might already know Alison, who does quite a lot of the paediatric stuff. There's myself, Phil and Kat, who all work in the heart team. And then there's 3 lung coordinators, Kirsty, Hazel and Tamsin, who, because we don't transplant as many paediatric lungs, you might not hear from as much. But yeah, so that's kind of that's the team. So what I'll do is I'll try and share my screen now. Let's see. I did it last time. Can everybody see that?
Yes, Steph, we're there.
Yeah, cool.
It's just not in slideshow mode yet.
That's
perfect. It is now. Thank you.
Brilliant. So I'm just going to talk you through basically the pre-transplant side of things, and I know Terry's going to pick up on the post. So it's mainly just to go through kind of what we do, and a little bit of when the children are on the waiting list and kind of how we work with other teams and other centres around the country in kind of maintaining patient safety, communication and making sure that we're kind of doing the best for the family and the child. So different types of referrals. So we do, I would say we probably have, in terms of who we transplant, about 50-50 in terms of acute admissions of patients who are newly diagnosed or have ended up bouncing into hospital, maybe a little bit less expectantly, maybe you've gone on an ECMO or have needed mechanical device to help support them. So these are usually patients who, or families who don't particularly have a lot of background information about transplant. It may have been mentioned briefly, but it's not usually something that they've got in their head that's something that's imminent. Therefore, they can find it quite daunting to kind of have that thrown at them. And obviously the child's very unwell, so it's trying to process all that information. You have less time to prepare with these kind of families, and it's usually a case of prioritising the information. So, you know, we could tell them the ins and outs of transplant, but what they want to know is what's happening right now. You know, if we need to go down a transplant route, how long is that going to take? You know, will my child survive? Is basically what they want to know and what they can process at that time. Whereas a planned admission, where we would have a patient come in for an overnight stay, we can go through what transplant is, we can touch on mechanical support, we can go through the pre and some post-transplant information, what happens when they're waiting on the list, all that kind of stuff, and then discuss them at an MDT in a bit more of a timely fashion. And then we can discuss with the family what we think is the best route going forward, whether or not they need to be routine or urgent. So it's a lot less chaotic, and usually the information that they're taking in is a lot more thorough. So it's kind of 2 different categories really of what we come across as coordinators daily. When we do have a patient coming in, routine or urgent, there is a certain kind of group of tests that we do regardless. So, you know, bloods and tissue typing. I'm sure a lot of centres are more than aware of the complications around HLAs. You know, the more sensitised a child is, the harder it is to get them a match. It's not impossible, but we don't desensitise patients pre-transplant very often, and it's difficult because it's hard to be able to plan that kind of care around an organ becoming available. and the success of that is not always guaranteed. So, you know, we're not always going to be helping by doing that. Each patient will have a chest x-ray. They've usually had multiple echoes by this point, but we'll get a new one. If they're a routine patient come in for a normal assessment, we'll do either a 6-minute walk test, or sometimes if they're a bit older, we will do like a bike test. That gives us a bit of lung function as well. The psychology and social review aspect, it's really, really important that that's kind of started before they come to us if they're routine. Even if the family don't feel like they need any support from a psychological point of view, or the child doesn't, even just make sure that all their social elements are dealt with, that they're claiming the right finances that they can have to help them. It's expensive coming up to Newcastle or down, and make sure that they're aware of what's available to them for support, because sometimes they think that everything's okay and that they've got everything they need, and then all of a sudden they're like, oh, actually, hold on, there's this to consider, there's that to consider. And of course we will throw new things in the mix, but if they've got that connection locally, it makes it a little bit easier than us starting from scratch. Dental review is the bane of my life. It's really difficult to, probably not as much in paediatrics, but dental work in dental hospitals is excessively difficult to get. Even getting a referral in, we've waited 30 months before to get a child dentally fit before you can put them on the list. It's an absolute requirement because it's the biggest source of infection. It's something that we can control and we can reduce that risk. Our dentists will see them when they come to see us, but we do regularly get patients who, you know, they don't like going to the dentist, and we totally understand that. It's, you know, children are children and they'd rather not be prodded and poked anymore than they already are. But at the same time, it does delay a lot of things. So dental review, or even having that initial review at home before they come up, saves so much time. Neck and groin Dopplers, we do that just to check that the patient's got appropriate access. If we were to go on to ECMO bypass, we need to know what access we've got, and occasionally, in more rare cases, that can be something that would exclude a child from going forward for transplant, because if we can't get the appropriate access at the time of the operation, then, you know, we can't proceed. An ECG, potentially a 24-hour one if we think arrhythmias are a potential problem. Obviously, if anybody's got any questions, please just put your hands up, or I think I can see the hand thing. This is kind of a bit of a kind of perfect process, I suppose, which doesn't always happen quite so smoothly. I would say sometimes this process gets broken in certain points, and we kind of jump a few steps because the patient might become more poorly, or sometimes the green section can happen a few times before we get to the blue section. So just to go through this, we'll have the referral process. So we'll have a referral in an ideal world where we will discuss this in one of our meetings, and as a team we'll decide whether or not it's suitable for a patient to be brought in for transplant assessment. If there's anything major outstanding, we'll often ask the local team to do that, because we know that if we bring them up, the likelihood is we'll then send them back to their referring centre and ask them to do the tests that we already know they need. So there's sometimes no point in bringing a patient up for a test that we know we can't get done in them 2 days assessments, which could be a larger test, or maybe something conventional that, you know, doesn't need us, can be done with a local team. So basically that part of it is to just check, are we at the right stage to bring the patient up for assessment? We'll give a date as soon as we know that we need to bring them up. Depending on how many children have been around, or if we've had a lot of emergency cases, it can mean that we've got a bit of a backlog, or we don't have beds to bring patients into. I know during COVID we struggled quite a lot. We do remote assessments, but we always have to see the patient up in the Freeman Hospital before we would actively list them. And that's so the whole team can see the patient, because what we don't want to do is have the opinion of one person who's physically seen the patient and the family. The rest of the team have all assessed the patient via paper, yet, we bring the patient up for a potential transplant a few months later, and the surgical team might think, I'm not quite sure that this patient is robust enough, or, things might have always changed, so they'll always get a fresh review when they arrive at the Freeman regardless. But before accepting into such a big operation, our full team of anaesthetists, surgeons, doctors, all need to be involved in that patient's care. Therefore, they need to have seen the patient. So that we do have a few questions every now and then from the family asking, why do we need to come all the way up to Newcastle? And it's for that reason, that the last thing we want to do is put a child through this process to get them to the Freeman to either say, actually, we're not sure that this is the right thing to do, or to put them through this process to bring them up and have not, had all the facts and figures before kind of consenting them for transplant. So it is really important. So once they've had their 2-day assessment and we've gotten all of the information we need, including images and sorry, got a bit of a frog in my throat. Any images that we need, particularly CT scans or MRI scans, we would then discuss at the MDT with our full team. So our surgical team, anaesthetists and intensivists, physiologists, everybody that's seen them. So, we have dietitians there, we have psychology there, physiotherapists, the play specialists. There's a lot of people, and they'll all kind of say their bit. If we're happy to then go ahead, then we would contact the team and the parents and explain what we think would be best going forward. And then we would also decide whether it need to be active or routine list. Now, 9 times out of 10, an urgently listed patient is a patient who's bounced in or got worse. It's usually someone who is a little bit more acute, and they're the patients who either need to be kept on milrinone. We have a very, very small selection of patients who would be at home who fall under the arrhythmia category. However, I can think of maybe 2, if that, off the top of my head, that we've had in that situation. Most of them are either patients who are on mechanical support or patients who have had, an acute bounce in a hospital and need milrinone and they can't leave. Now, some of these patients could be from other parts of the country, so it doesn't necessarily mean that they're in the Freeman, but they would have been at the Freeman at some point for a full review and kind of like a final sign off before being put on a list. So this is my lovely little man. This is kind of what I feel like patients and parents feel like when they come to the Freeman. It's like they try and squeeze all this information into the head, and we know that there's only so much patients can actually take in at any one time, patients and parents, and we do try and obviously tailor it to the family and to the patient. but it's not always that easy to establish exactly how much they've understood. This is why we go back a couple of times when they're there. We give them a bit of time. We let them have a few tests done. We go back. We'll ask them a couple of questions just to try and get a feel for how much they're taking in. So knowledge and consent. So the knowledge, you know, there's a variety of people that come to see us. Some patients are a bit older, they want to know stuff. There's some patients who are a bit older, they want to know everything, but the parents are quite protective. And it's trying to get that balance between not completely keeping a child out of the loop, because they're going to find out eventually. However, it does depend on the patient, you know, their needs, their level of education, how much they want to know, and how much they already know about their health. We've had such a variety of patients over the years, which I'm sure the post-transplant team will absolutely back us up on, where you go from one extreme to the other. Basically, you have some who come up and they think they're coming up for a routine checkup, and then we have some kids who know exactly why they're here, and they know they need a new heart, and that's what we're looking at when we bring them up. So yeah, it does depend. And what I always do is check with the family, how much does the patient know, and how much do you want us to talk to the patient in front of them, or do you want us to take you away and do the bulk of the education separately, and then we can feed back depending on the outcome of the assessment, which is what a lot of parents like to do, because sometimes it might be that the patient just needs to come back for a review, and we're not quite at that stage yet. So rather than being in a position where we worry the child, we'll wait until we know the answer. Now, occasionally, it kind of goes in the opposite direction when we're saying, you know, we're getting to a stage where we need a list, and that might be urgent. And the family are very reluctant to even go into the fact that the patient's staying in hospital, or the patient is, you know, quite sick and will need a big operation. It's trying to get that balance. So consent can be dual. Obviously, that is not spelled right. It can be just sometimes the patients, certainly older patients, want to be involved in their own care, so they can do a dual signing where the family, the parents sign as well as they do. And it's trying to kind of get them involved in their own care. And I would say that the older children do definitely engage. And it's rare that they come, if they're in the teens, it's rare that they come completely and utterly out of the loop, although we have had a couple. We did a bit of research a few years back, and we found that the average adult takes in about 20% of what we tell them when they're here, which is not a lot. And it is it any wonder we give they go through a lot when they're here. Therefore, it kind of makes you want to be a bit more selective of what you tell them. So as much as we do go over risks in the post-transplant journey, we go over the more prominent things that they need to know before signing a consent form, rather than, you know, what the side effects of tacrolimus are. They need to know that the overall side effects of immunosuppression can be reduced kidney function, cancers, increased risk of infection, those kind of things. But we wouldn't go through every single side effect that the patient might get post-transplant and which drugs we might change them to. So those are things that we wouldn't kind of focus on, because we know that it's not useful at this stage. We are going through a process of trying to update the education system. What we would give parents education-wise and what we would give the patient are quite different most of the time, is what I would say. The parents we would give them all information. I sometimes give them, there's a link to NHSBT, which kind of goes through the process of transplant, and we have one for the adults. The problem is that it is aimed at adults, and it's aimed at the adult journey rather than the paediatric journey. Obviously, there is some differences. However, I think it does bring it together quite a bit, and I think people do find it useful, depending on how much they want to know, I guess. But we do touch on, well, we go into the risks of transplant, and that's something that we will focus on, because that's the main bit that they need to know what they're signing up for, basically. And then the patients, we'll sometimes go back to them once we spoke to the parents to give them a bit of an idea of what we've been chatting about, so they're not completely out the loop, and try and aim at what they already know. Sometimes parents want to go and speak to the children themselves when they get them home, explain to them. It's difficult because you don't really know what's been conveyed to the child, and that for me is quite hard, because I always wonder how much a child knows before they come in for an actual transplant, if we call them in. However, there is a degree of that is out of our control, which I am now starting to come around to after 8 years. So these are the things that we go through. Let's see. So why we transplant? So it's life expectancy and quality of life. We don't do it to give somebody quality of life alone. It is a palliative care option, essentially. It's not a fix. It doesn't make anybody better as such. It's a swap. We are swapping one set of problems for a hopefully nicer set of problems, with a longer life expectancy, which is the main thing. We've got massive limitation when it comes to hearts. We can't, if we gave everybody a heart transplant that wanted one, we would soon run out very quickly. We go about what happens when patient is sitting on the list. A lot of our patients are routine. They're at home, they go to school, they stay under their local centre. The local centre keeps us up to date with what's going on, and they'll have regular bloods, they'll have regular checkups, and the centre will report back to us with any concerns or worries. The waiting time, that's usually something that patients and families struggle with. On the routine list, it can be, how long is a piece of string? When they're little, it can be an inevitable wait to urgent listing. So they might start off routine, but eventually they'll end up in hospital waiting because they'll not get done off the routine list. So that's usually probably from a baby anywhere up to 5 or 6. They're really difficult ages to find hearts, because a lot of our in-house patients are all within that age range. So there's a lot of competition in that sense. We talk to them about going on holiday, trying to keep things as normal as possible, keeping healthy, dentists, making sure that they have regular, follow-ups with their local team, communication. We need to know if they're unwell, if they're in hospital, any antibiotics. Sometimes they have a new diagnosis and it's been discussed with the local team and they all know, but then they come up for a review with us and then all of a sudden, oh, well, we've got this and we're now seeing such and such for this. And that can sometimes be quite significant, because what we don't want is too many organs all impacted by different things, because that makes post-transplant recovery and management very difficult. And we need to make sure that the drugs and the treatment we give post-transplant is safe and effective. So it's really, really important that we get a lot of communication from the family and the local team. We go through the difference between routine and urgent listing. Getting the call. So a lot of people panic and say, do we have 4 hours to get in? No. It's one of the biggest myths of transplant. That is our job as coordinators, is to get the patient in, prepped for theatre, and ready in a time frame that we have discussed with the donation side. So that's all taken care of. We know where all of our patients are in the country and we factor this in. So basically all we ask is that patient can get to can get to some transport, whether or not that's transport we've arranged via a local ambulance service, which is not the easiest thing to do these days, or their car, because a lot of families would just drive to the Freeman themselves. We all factor in how long that's going to take, and we would get a retrieval team to attend the hospital at a particular time, knowing our patient would already be at the Freeman. We've had a couple of quite close calls where there's been a bit of an overlap, but that's our job. That's what we're paid to kind of organise. So that's our stress, not the family stress. So all we want them to do is to be able to leave within an hour, and then we'll do the rest. So they'll come into hospital, they'll have a range of medications, not medications, tests done. So chest x-ray, they'll have some bloods done, we'll get them prepped for theatre as if they were going to go for a procedure, and then potentially consent, because not all patients have a written consent before they're put on the list. And then we do all the rest in the background. This 4-hour thing has come from, we don't like the heart to be out of the body for longer than 4 hours. But by that time, the transplant process is so far on its way, that's not actually something that the family needs to be worried about at all. So this is actually, I mean, it's a really blurry picture, but this is actually our team. So part of our team. So we try to kind of give them a little bit of an idea of, you know, what happens next. So if the organ's not suitable, they go home and we start again. It can be disappointing. It can be nerve-wracking in that kind of particular time frame where, you know, sometimes when a patient comes from home, especially if they're routine, everything hits home when they get to the Freeman if they get a first call. For kids, it's more rare that it wouldn't go ahead than it is for adults. However, it can be quite it's very adrenaline heavy, and it can be really disappointing, yet a big relief if it doesn't go ahead. And sometimes it can highlight some issues with families and whether or not they're prepared or whether or not they're ready. A no-go for me is sometimes not always the end of the world. Dear me, I do apologise. That was a lorry outside by the sounds of it. So we go through moving to theatre. Most parents, what they want to know is the logistics of things. So can the parents come into theatre? Yes. Can they have a pre-med? Yes. Sometimes we'll get the team to go down and bring the patient up to theatre, because that means that they've already met a couple of the members of staff. An anaesthetist will go down and see them, the surgeon will go down and see them, they'll see the coordinator. So we try and introduce people before they get up in the theatre, just to try and relieve their anxiety. We go through getting put to sleep, pain control, and the time of the operation. So we kind of go through those things. Now, this, from our experience, is where patients start to kind of get a bit overwhelmed, or parents, and kind of switch off a little bit. We go through the risks. So kidneys, clotting, bleeding, primary graft dysfunction, infection, rejection. And we see a 10% mortality risk within the first 12 months following transplant. So that's from being transplanted to a year after. You know, that can be higher depending on the patient. So depending on whether or not they've already got kidney dysfunction, whether or not how long they've been in hospital, how many previous surgeries they've had, what their primary disease is. So we give this as a generalized information, but it will be geared towards that specific patient at the time of our discussion in our MDT. And if we think that's higher, that would be discussed with the family, and we are honest and we explain, that the impact of HLAs can also mean that the likelihood of them getting transplanted could be lower. Sorry, all my photographs are a bit blurry. This is a post-transplant team. I say team, it's not at all. This is the ward staff plus Mohammed and Louise. So I don't know if there's actually any post-transplant nurses in there. I can't see because it is really blurry. But this gives you an idea of some of the people that work down on the ward, on ward 23 and PICU, which are the two wards that they're the only two wards in the Freeman, but that's where the patient journey is PICU, and then down to ward 23. And that's one of our little post-transplant children with our teddy bear. That's obviously been to theatre. So, and then this is one of our patients who are currently waiting for a transplant at the moment. Look at as cute as a button. I've put the link on for the NHSBT information tool because actually it is quite good. It's very informative, although it is geared to adults. So it's good for the families, not so much for the patients, but that's why we are currently working on an education tool to help with that. And I think some centres have got, things with drawings in and little cartoons and that kind of thing. And that's kind of the route that we're hoping to go down, to try and, I suppose, try and include children a little bit more in the education process, because then it'll be easier to engage them into what's going on. Obviously, it absolutely depends on the child and it depends on the age, and there's a lot of potentials, but there is some work to be done with it. But I think overall we do make sure that the parents are as informed as we possibly can prior to them kind of being actively listed, and that's kind of where the patient would go into theatre and the post-transplant team would take over from us. We do communicate with them, and if there's anything that we do find with the parents that we think they need to know, we'll always touch base and say, this family might struggle with this or that. But other than that, I would say that that's kind of in a very, very brief nutshell, kind of what we do pre-transplant with the patients. I've kind of done there's a little fact sheet which I've given to Terry, which is happy to kind of feed back to people once this is all finished. But this is just a little slide on kind of what's helpful from other centres who have referred their patients up to us. So regular updates, changing circumstances, whether that's medical, social or psychological, dental check prior to assessment. So yeah, it just kind of gets the ball rolling really. Psychology support locally. Sometimes we'll refer to psychology and they could have come back for their next review and they've only had one session because it's taken so long to get to see. And it's no one's fault. It's the the nature of the game, unfortunately. But it's helpful to know that they've started that process. If it's required. An earlier referral is helpful. Obviously still needs to be medically appropriate, but it means that we can help plan. And even if we say, actually, we can offer some conventional surgery. However, it is possible that we may be going down this route in the future. Then it kind of plants the seed in the back of the parent's head of, actually maybe we can buy a bit more time. However, there is a possibility in the future that we may have to, you know, really consider this. And it means that when that conversation does come up in the future, it's less of a, you know, less of a shock and less of, you know, a daunting experience maybe. And, you know, depending on their child, they can kind of filter that in dribs and drabs rather than having to have such a shock element, I guess. Yeah, realistic expectations, just in terms of that, I think we get such a variety of patients, and I think what they will take from their referral up to the Freeman, regardless of what you say to them, will be different every time. Some people just will only listen to what they want to hear. So they think, oh, well, if I can get up with the Freeman, we can get a new heart, everything's going to be fine. You could have told them the exact opposite, and they still will not listen, I guess, because that's hope. It's all they want is hope that their little one's going to be okay. But I guess trying to manage their expectations is important from all sides. If in doubt, just give us a ring or ask us, drop us an email. We're always happy to help. And HLAs, we can, if you've got a patient you're going to refer up, just give us a shout. We can send the blood bottles down or tell you what we need, and we can send them off. It's a separate lab, it's not done in the Freeman. It has to come to us, and then we request them on a separate form. But we can always check, and then that gives us a bit of a direction of care even before they've come to the Freeman. Because if they've got 99% sensitized antibodies, then we know that the likelihood of them getting transplanted is extremely thin, very small. So then that's something you can kind of start feeding back to the family and maybe focus heavier on a different direction of care, having transplant in the background rather than a patient who's got no antibodies at all, therefore wouldn't exclude any of the population of donors, who's much more likely to get a transplant, in which case you would put that one, maybe direct that patient towards the transplant chat more so. Oh, and that's it. There I'm up to. Oh, hold on.
Thank you, Steph.
Do I click stop sharing?
Yes, please.
There
Can you put your camera back on for a second for me?
you are.
Thank you. That was brilliant. Thank you. Roller coaster ride through what we know is not as straightforward as that, but you made it sound like a beautiful pathway.
Yeah, if only, yeah. But yes, kind of it in a nutshell. If there's any questions.
Yeah, so we've got a couple in the Q&A function. I'm hoping you can see the Q&A function, Steph, and if you can stay online and answer a few of the questions that we don't get a chance to go over. But one of the questions, I think you have just fully covered it in your last slide there, from my colleague Susanna, and she said around, how do you see the role of the referring hospitals in the patient and parent education and preparation for transplant? So you talked very much about dental and psychology. So do you see the referring hospital very much in that sort of the holistic well-being, the patient being as well and as prepared?
Yeah, I mean, it is difficult because, you know, if you don't work with transplant day in, day out, we don't expect the referring centres to know all the information we're going to give the family, because that's why they come to us. I think it's trying to keep the expectations realistic, where, you know, it's not you're going up to Newcastle to get a new heart. No, you're coming up for an assessment. And what we like to say is it's a heart failure assessment. It's, yes, transplant's heavy on that, but can we change medications? Can we give some conventional surgery, which may push transplant off for a number of years? We need to look at the patient. It's like an MOT. That's how I describe it. And we need to look at all the different bits to make sure that we can get a child safely through an operation and give them the best quality of life afterwards. If there's any little bumps in the road, that might put that risk too high, and then we need to look at a different direction of care. And it's more trying to, I suppose try to realistically explain that this is an assessment for a potential treatment rather than you're going to Newcastle to get a new heart and everything will be fine. And I don't think that is absolutely not how we think that it's sold to the family at all. But sometimes, regardless, and doesn't matter how hard you try, that's in their head because that's what they want. And it's not that's what they've been told, but that's their hope. They're holding on to that because they want their little girl or boy to be better. And that's completely normal. But if we're all saying this is an assessment to see where we go next, then they're getting told by everyone, and eventually it'll kind of start to sink in that actually this might not be, that magic wand. So it's just trying to, if we're all saying the same thing, then they'll kind of, because sometimes people do come away from Newcastle a bit disappointed and a bit disheartened, and they think, oh, well, they've said this and they've said that might not happen and this might not happen. And I suppose it's just reiterating the same thing over and over again. Eventually, it makes it a little bit easier because eventually they will start to kind of to get the right idea.
That's great. So very much around the language we use. I think in answer to Susanna's question is us all saying the same thing around it being a heart failure assessment, not transplant assessment. That's brilliant. Thank you. We do have time for one more, if that's okay for you. And then Stephanie will go on and answer the questions that are in there. So there's a few questions in there around non-urgently listed children at home. One of them being quite a specific question, so we'll do that one. In terms of being on the waiting list and being a long-term waiter who is at home, not an inpatient, how often would you repeat bloods and do a review generally?
Well, that depends on the local team. A lot of the time, these children a lot better than what we do. We'll see them, certainly we assess them, but we don't know their history or them as well as you guys do. And that's why we rely so heavily on you guys to, what my advice would be is pretend they're not on a transplant waiting list and they are a patient under your care. So it needs to be what you think is clinically suitable for that patient. If you see them and you think, actually, they're not quite as good as they were before, bring them back a bit sooner. Or, and I know it's probably like, okay, as a minimum, what would you like? Again, that's up to your clinical judgment, really. Probably every 3 months, I would say, if that's what your normal practice would be. But I wouldn't allow it to go much further because then that's quite a long time to not know what's going on, sort of thing. We do try and make sure that our patients are brought back and forwards on a regular basis to make sure that we know what's going on. But sometimes that could be 6 to 9 months because we're looking at them from a slightly different point of view. So we're not there for general medical management. We are there from a surgical transplant point of view. So it's just trying to make sure that you know what's going on with them and they can relay that to us.
That's brilliant. Thank you. Yeah, would really appreciate if you do have a couple of minutes, just check some of those questions off. I'm sure your colleagues will support with any you don't get round to. Thank you so much for your time this morning. And I will end your session there. Thank you very much, Sarah.
Bye.
Thanks a lot. See you later. So we are almost bang on time. And then, so after Claire's session, we will have a comfort break. Oh, and as if by magic, there she is. So I'll hand over to Claire McGrath, who is our heart failure and VAD nurse specialist based at the Freeman Hospital. And she's going to take you through the bridging element of the transplant pathway. And she's very delightfully called it the waiting game. You're just on mute there, Claire. So whenever you're ready, it's over to you.
Hi, thanks for inviting me to join you all on the study day today. So like Kay said, I'm just going to kind of touch on a bit of the waiting game for our patients. So So a little bit of a brief history. So we're one of 2 centres in the UK to offer mechanical support to children. So obviously ourselves and Great Ormond Street in London. And here at the Freeman, we started our transplant programme, our VAD programme in 2003, and then got it really properly established in 2005. And since then, we've done around 200 paediatric VAD runs. And over the past 21 years have provided approximately 16,000 days of VAD support to children. So today we just aim to give you all a bit of a brief overview of the fundamentals of VAD and look at the different types of VAD that we use in children here at the Freeman Hospital. We look at those risks and complications that are associated with VAD and the waiting time and the effect that this can have on the whole family. I think, as Kay said before, if anyone's got any questions, feel free to pop them in the question and answer bit. But as well, I thought as we go on, if anyone wants to pop into the chat, kind of as we're going through and talking about VAD, if you can think of any, if you can think of the impact that it might have on the child and the family, please feel free to pop it in there and we can kind of collate those at the end as well. So this chart here kind of shows you the transplant list, the active transplant list from 2014 to 2023. I'm not sure if Steph touched on this previously. So you can see that black line at the top shows the active non-urgent children on the list, and that blue one shows the active urgent list. And you can see that's increased and then became a bit more static over recent years, but that on average we have between 13 and 16 children on the active urgent transplant list. And then you can see here that the median waiting times for transplant have nearly tripled in the period 2019-2020 compared with that of 2014 to 2017. And this map shows where our heart referrals come from, the heart failure referrals, sorry, and we accept children from across the UK and Ireland. And we'd like to live in this world where we think the children from Scotland could come to us and the ones further south could go to Great Ormond Street, but it doesn't always happen like that. And it's kind of normally around where there's bed availability at the time. So we do take children, a lot of children out of region, and obviously that has a huge impact on families and the children. So the number of children who require a transplant far outweighs the number of donor availability, and therefore that's why we need the mechanical support as a bridge to transplant. And 41% of our transplant patients are supported with a VAD. And in the paediatric population, mechanical circulatory support is mainly used as a bridge to transplant, but it can also be used as a bridge to recovery in patients who've got an acute myocarditis. So what types of VAD are available? So we've got some short-term VAD, so we've got Impeller, and this is a device that we've just recently started to use over the past year. We've supported a couple of patients on this pump, and it just supports the left ventricle. So we need to ensure that they've got good RV function. And this is inserted through catheter through the axilla or the femoral. I think in adults, they use it far more often and they're able to have access through the axilla, and therefore patients are able to be woken up and are able to mobilise around. However, due to our patients being much smaller, it's often more difficult to access the axilla. And in the 2 patients we've used Impeller in, we've had to go through the femoral. It's secured with a dressing and it's not secured or fixed, and therefore can have misplacement. The aim is to wake up and mobilise these patients. However, as I said before, because we have been able to use the axilla and had to use femoral access, our patients have remained intubated and ventilated. It's for short-term use, and the company would recommend support for up to 30 days. It gives a minimal inflammatory response. There's no need for stenotomy. So the positive is when they go for transplant, it's the first time going to theatre and having the chest opened. These children are nursed in our paediatric intensive care unit and they remain super urgently listed. So another short to medium term VAD is Levotronics, and this is best used for short term device and supports for weeks. And this can support patients of any size and offers support to both the left and right side of the heart. It's a continuous flow pump and is a simplified ECMO circuit with no oxygenator or pigtails. The Berlin heart cannulas are durable and are designed to be connected to the heart and to the Berlin heart pump. However, for our patients, when we put them on support, we connect the Berlin heart cannulas to the heart and then connect them up to the Levotronics pump. This procedure involves a sternotomy and bypass, which stimulates that inflammatory response. And our current practice is to implant Berlin heart cannulas, connect them to the Levotronics system, and then once the inflammatory response settles, we've got our patients stable on some anticoagulation, we change them to the Berlin heart ventricle, which is a more medium to long-term device. We have had a few children who have had their course of VAD treatment on Levotronics, and they remain in PICU and are nursed there. Although for those children who have been on Levotronics more long-term, we do extubate them, we get them out of bed, they have some physio sessions on the floor, and our aim would be we'd get them down to the playroom where possible for some sessions so they're not confined to that PICU environment for the whole time. And these children are on the urgent transplant list. And then the Berlin Heart X-Score is one of the long-term VADs we use, and this offers paracorporeal pulsatile flow to either the left ventricle on its own or for biventricular support. And it's a long-term VAD suitable for children of all sizes, including the smallest and youngest of children. And currently, this support is offered to those children who are above 5 kilos. It supports children for any length of duration. So we have had children on this for days, weeks, months, and we're now seeing much longer wait times and have had several children on the pump for over a year. And our longest support time for a patient on Berlin Heart is 751 days. These children are at risk of complications and are quoted a 25 to 30% chance of stroke. Over the past few years, we've worked in collaboration with Berlin Heart on the production of the active that you can see on the screen there. And we were one of the first, we were the first centre outside of Germany to use the Berlin Heart active. And the revolutionary new device has completely changed the lives of those children waiting for transplant. It's a much smaller and more portable device, which means children are now more mobile. You can see on the screen there, under the X-Score components, the machine on the top, that driving unit, is what we used to use, the ICIS. So that weighed 115 kilos and it had a 30-minute battery life. We're now very lucky to be able to offer all of our patients the device at the bottom of the screen there, the active, which weighs 15 kilos and battery life of about 7 hours. However, they've got spare batteries and they can move around much more freely. We've got a great education package for parents and families so that they can be independently mobile as much as possible within the hospital grounds. The device currently is not licensed for use off hospital grounds. However, we have been able to offer some trips out for the children whilst waiting. They quite often like a trip to the park, which is just over the road from the hospital here, where they can feed the ducks. And at Christmas for the past 3 years, we've been really lucky to work with Nectar, our transport service, the team, and we've been able to take the Berlin Heart patients to visit Santa at a local department store in town, which the families have really benefited from. So these children are currently nursed in our high dependency unit, and at present we're looking at further exploring opportunities for independence for families as well. These children are urgently listed for transplant, and as I said previously, they'll spend the time in hospital here with us. So HeartMate 3 is another long-term VAD we use here at the Freeman, and this offers support to the left ventricle. So we need to ensure our patients have got a good right-sided function. On occasion, some of our patients do need to come back from theatre with some short-term right ventricular support. And when we're in theatre, if we think the right side's struggling, they might come back on levotronics temporarily on the right side and be able to get them back to theatre and wean that off. And in a couple of patients, we've had them on 2 separate devices. So we've had some patients who've had a device similar to HeartMate 3. Heartware is what we used to use. They've had Heartware on the left, and then they've needed Berlin heart support on the right. So the HeartMate 3 is a continuous flow device, and it's got this full magnetic levitation flow in the pump, and this maintains gentle blood handling and minimises complications and hemocompatibility related adverse effects. They have a 0.1% risk of pump thrombosis. It's fully levitated. It doesn't require, there's no mechanical bearings inside the pump. It's got a large, consistent blood flow path, and that reduces the shear stress. And it's got some intrinsic pulsatility to reduce stasis and minimize thrombus. This pump is one size fits all, which means it's not suitable for our younger children. We use it in those above 35 kilos. It's fully implantable, as you can see on the picture on the right of the screen there. It's implantable, and we have a drive line that exits on the abdomen, and the patients carry around that controller you can see on the front of the torso, and those 2 batteries at the side. Because it's a portable device, we put children on this with the aim of being able to discharge them home once they're stable. Once stable, we have a big education package with the families that we go through, and we have an aim within about 10 weeks to try and get these children back home, and we try to get them back into full-time education. Unfortunately, sorry, I'll just get that off the screen there. Unfortunately, these pumps are amazing in adults, and they send them home and they lead that independent life. For children, we're putting these devices into them at a time when they're just wanting to get that independence and start exploring the world without an adult around them. However, when we send children home with this pump, they need to be with someone at all times who's fully trained on it, whether that be at home or at school. So I think just to bear in mind, they're not small adults and they don't have the same independence when they get home as the adults do. We see them in clinic every 6 weeks, and these children are at home on warfarin. We send them home with a Quaggy check machine, and they'll do the INR, and they'll give us a ring, and we'll dose them from the hospital here. The children are routinely listed once this pump goes in. It's classed as a long-term durable support, and therefore they have a routine listing status. And obviously this increases the wait times. And our longest length of time on support for a patient on a Heartware, which is a very similar device to the HeartMate 3, is 1,038 days. This pump just came out recently in the last 3 years, and we've implanted 3 patients with this pump, 2 of which couldn't go home because of right-sided failure and needed some inotropes. The other patient has been home for a year now and back in education since last August. We've briefly gone over the types of devices that we use here at the Freeman Hospital. So thought just to go over some of the comorbidity and complications that we can see. So some of our patients need dialysis because they've had a renal hit. We have patients who get sepsis through lines. Obviously, we need lines in to be able to give bivalirudin and to be able to sample. Some of our patients have arrhythmias, experience complications with drugs. We have strokes, whether they're thromboembolic. Patients have to have procedures for neck and have had laparotomies. A few patients might need a tracheostomy, cannula site and driveline infection. Some children who present with late RV failure, delayed physical development, intracerebral hemorrhage, embolisms to the bowel. Some children have feeding problems, and some need some chest reopening and exploration. If we think about the types of VADs that we've looked at, those three, and then if we think about that in relation to one of the first slides I showed, where it kind of shows you where we can accept patients from across the region, so some of the effects that this might have on the family: disruption, we're tearing families apart, families who aren't local, who come from down south, or I guess even our local families, we're bringing the children into hospital for long lengths of time, and it's that disruption to the family. Other siblings who may be staying at home with other family members. We've had some families who want to remain as a family unit as a whole, and we have the Sick Children's Trust here at the Freeman Hospital of Scott House, and they can help provide support to families and siblings. And our social work team work really hard with the families, and for some we've completely relocated families and have found local school places for siblings to attend so families can stay together. For those who decide not to do that and try and kind of keep a bit of normality at home for the children, and one parent be here with the child, you have those issues of separation and how that is. Stress is a huge one, I think, for all of our families. They're living with uncertainty every day as to, is today the day we're going to get a call and we're going to get an offer for a transplant, or is today the day that something dreadful is going to happen and we're not going to make it to transplant? That psychological distress with anxiety and depression. We have families who are experiencing a lot of loss and grief while they're here, the loss and grief of the life they had, of the well child they had, while trying to adapt to the new situation they're in. For those who are with us for large lengths of time, they have this cabin fever and institutionalization. There's obviously a lot of practical strain on the family as well, a lot of trauma, not just of things that are happening to them as a family, but that are often witnessed to a lot of trauma to other families while they're here as well. We have families who are here for such a long time that they make such close relationships with other families, and they experience loss of not their child but someone else's. That uncertainty and hope for the future. Parents are in some denial, overwhelmed with the responsibility of VAD-related cares, whether that's in hospital whilst they're on Berlin Heart, or especially those who were sending home on HeartMate 3, how that must feel for them to be going home with the child with a pump, and if that pump stops, then the child's not going to have any heart function, and real financial hardship for the families as well. So this slide probably just touches over some of the things I've mentioned on the previous one, what long-term admission looks like to the family. So you've got all those environmental factors of for parents, of employment, financial issues, housing, how can they keep a house running at home and trying to run a house from Scott House. We have families who aren't from the UK, so we need to help getting that with the residency and visas. Hospital accommodation. Scott House that we use is fantastic, but can only accommodate 4 people, so it's not great for our bigger families, and the schooling that I've talked about. Those relationships with the hospital, coping with all the medical information, and part of our role as specialist nurses is to meet with the families frequently and just make sure they're up to date and they're understanding everything that they've been told, and a huge support mechanism for them. A lot of them describe life as living in a goldfish bowl. Sometimes they're scared to give the children wrong because they don't want to be seen to be shouting at them, and vice versa, and the positive and negative feelings. We never forget about the siblings, and we offer some practical and emotional support for them. Our play team will offer some sibling support sessions and work with them. We try to make sure that they're not the forgotten ones and include them in the things we do. And we're happy as a team, I think I speak for the VAD and the transplant service, we're more than happy to work with the siblings as well and talk through what VAD is, what transplant is, and what life looks like, just so that they're kind of not in the background scared of what's happening. So I'd like to share a video with you with consent of the family, and I hope this kind of highlights some of the what a VAD journey looks like and the impact that it has on a family. So please bear with me. So I hope the video kind of give you a bit of a snapshot as to what our families face. I can't watch that video without crying, so I do apologise. But I think to put it all into context, that this family came to us at the beginning of COVID, at a time when only one family member could come in and see the child in our intensive care unit. So we took this little 6-month-old girl in, put her on a Berlin heart, and actually just watched her thrive and grow. She did amazing. She had an amazing family who were there to support her. The family were from Birmingham. Dad tried to stay down there as long as he could, but I think probably 18, 19 months into the journey, they really started to find it hard and decided to completely relocate the family. So they now live up here with us in the northeast. We found new school places for this little girl's brother. Throughout the whole journey, he couldn't go into Scott House because of COVID. They weren't accepting siblings back in. I think she did fantastically well, and then unfortunately she had a stroke, which again is one of the complications of VAD. And I remember ringing her dad that day to say to him, We need you to come. We're going for a CT scan. I'm sorry, we think she's had a stroke. And his reply to me was, don't be sorry. I've waited something like 18 months for someone to ring and tell me this happened. We knew it was a complication and we probably weren't going to escape it. I'm pleased to tell you all that after 750 something days, this little girl had a transplant and is now at home. We'll be getting ready to start primary school in September, and they have the best life. And although they had a truly rubbish time here with COVID, the family was completely torn apart. They saw lots of other children come in and be transplanted while they sat and waited so long. They saw some families not take their children home and experience what that was like for them, and tried the best to support them. Last time I saw Becky, Mum, she said to me, look at her, just look at her. She said, do you think people would think I was stupid? Because if someone said to me, would you do that all again? I'd do it again, and I'd do it for double the length of time, because look what I got. I got my little girl and she came home and she's having a great time. So I think in conclusion, we definitely need these devices to help bridge transplant, to bridge the children we see to transplant. And I think over the next few years, we'll see some more devices coming out, and we might get those smaller those HeartMate 3 devices for our smaller patients. Once on a device, we can hopefully get see improvement with renal, liver, gastro impairments, with the aim of VAD being to improve the quality of life and allow patients to rehab. We want them in the best condition pre-transplant for the best outcomes post-transplant. I'm teaching on another VAD study day today, and we've just kind of done an overview, and I think everyone agreed probably in the last 4 years the quality of life for the children who are inpatients on a Berlin heart has improved massively. That this doesn't just impact the child who's in hospital, it impacts the whole family, and it's so essential that we get that support right from the beginning. We're seeing such longer length of wait times, with on average a year. Probably 4 years ago, if we had a child who was at the age of 9, we might expect them to wait maybe 4 months, hopefully, and they might be through and transplanted. We're seeing the children of a bigger sizes waiting 9-10 months, those smaller children waiting in excess of a year. And when we're first meeting with families, we are counselling them that they're going to be with us for a year at least. I think the much smaller, under 12 kilo children, we're probably telling them 18 months to 2 years. They're here with us for such a long time. And that there's a constant threat of VAD-related complications, including stroke and bleeding and infection, which can lead to death prior to transplant. Has anyone got any questions? And please feel free, if you want any more information on any of the devices or what we do, please feel free to email me or give me a call. If you've got a patient in your centre now or in the future who you think is potential to come to us for VAD, give us a ring. We're happy to chat with you. We're happy to send some information through for the families. We're happy to talk to them, and we can kind of give them a bit more of an idea of what life might be like with us. So I think the biggest thing for the referring centres is just getting the message out to the families. They're coming for us for an assessment. First of all, are they a VAD candidate? Can we VAD them? Are they a transplant candidate? Most importantly, before even being a VAD candidate, and preparing them for a lengthy stay with us. Thank you.
Thank you so much for that, Claire. For some reason, my camera's just having a bit of a moment. I'll sort it out over break. So I'm going to have to talk to you without a camera. Can you still hear me? I've got the whirly swirl of doom.
Yeah, we can hear you still.
You can hear me. My whole screen's gone blank, so I may get cut off in a moment. It says it's not responding. Thank you for that. There's a few comments around, I guess, the emotive nature of everything you've just said. And thank you for sharing that film. I also can't watch it without crying after watching it so many times. It's such a powerful piece of work for my dad. I have a question, I think, just while I wait to see if anybody else puts any in the chat, although I've totally lost everything now, so I'm going to wing it. Around, I guess, morals and ethics, Claire. We don't want to delve too deep into this, but I think it's important to acknowledge when you talked about the comorbidities of VAD and the risks and the sort of the associated problems that come with VAD. Do those sorts of questions come up along that pathway around the sort of, are we doing the right thing for this child when they are susceptible to sepsis, when they're really quite poorly? So you're maintaining their life on VAD. Can you share any insight around sort of that, please?
So do you mean, does it come up from parents' care or within
both?
the team?
Yeah, if you could give us both perspectives, that would be really.
When we initially get the children, when they present to us, most of them are kind of already in real end stage heart failure. Some of them are already on ECMO, and they come to us kind of in a state of, if we don't do something, then the child's going to die. And I think at that time we give parents all this information, and how much they retain, I don't know, because you must sit there and present it to them. But then what we're saying to them is, you can go down this really, really hard, tricky journey of lots of complications to hopefully get to transplant, or we could do nothing now and the child's going to die. We have some parents who really, really sit and think about, what does quality of life look like for them and their child, and is it something they want? We have had families when there's been other like genetic diagnosis who decided, when that was confirmed, that actually they didn't think this was in the best interests of their child and didn't want to pursue things. You also have other families who maybe have had a real smooth journey, and then they hit a bit of a bump in it, and the child has lots of issues with infection and are becoming sicker and sicker. And we've had a few families who then get to a point and say, we don't think this is fair anymore. We think our child's suffering. Sometimes as a team, every week we sit and discuss all of our VAD patients in an MDT, and we do talk about quality of life. And it's just also worth noting, we work really closely now. We've got the CHIPS team, which is the Children's Holistic Integrated Palliative Service, and we introduced them as part of our team at the very beginning of VAD, and they offer us some support to us and the families, and help with that parallel planning. I don't know if I've answered your question very well, Kay, sorry.
Okay, that's great. Kay's just let me know that her computer's kicked her out. So if there's no further questions, Claire, if you don't mind answering just the questions in chat now, and we'll go on a break and we'll be back for 10:45.
Yeah, that's perfect. Thank you. Thanks everyone for listening.
Thank you, Claire. Much appreciated.
Hello everybody and welcome back. We're going to try and keep on track with today. I'm just reflecting back on some of the questions in the Q&A box there. Some brilliant questions coming in. I hope you're getting the responses from the team that you are looking for. If not, just keep typing away the questions and we'll just keep communicating through that channel. So we've kind of got to a midway point throughout the programme for today, thinking about how the children get to referral point considered for transplantation, some of the options available to maintain and support during that time waiting for a suitable organ. And now we're going to explore the first 30 days post-transplantation. We've got a double act for you delivering the next part of the session. We've got Dr. Yemba Ajanaka and we've got Antonia Phillips, and I'll allow them to introduce their roles within the team itself. And they're going to take us through the 30 days post-transplantation. Guys, are you there?
We're here.
Yes, you are. Thank you. I'll hand it over to you.
Can you see the screen from us?
Yes, we can. Perfect. Thank you.
All right, thank you. Can you hear me? I tend to.
Yes, perfectly.
All right, thank you. All right, so my name is Yembe. I'm the transplant fellow working with an amazing team here and still learning as I go along. So we're just going to look at the journey, the first 30 days of post-transplant, what happens coming from theater and then moving on. So I'll just take a part of it. There's some places I'll just do like an overview and then Antonia will elaborate more on that. Also some things I'll touch on. I think Abbas will come in later to also touch on about complications of heart transplant. So I'll just go on. So I think the heart transplant, the whole journey is actually the real deal when it comes to MDTs. There's so many teams involved in getting the patient ready to eventually have a heart transplant. We've seen that from transplant assessment and come down all the way. And we'll see how it still goes on with an MDT taking center stage with just getting these patients through this journey as quickly as possible and in the best possible way. So we'll just look at briefly returning from theater and onto PICU. And the heart transplant could have been a mismatch. It could be size mismatch, ABO resus, it could be a CMV mismatch as well. And these all come with their peculiarities in how you manage the patients going forward. Post-operatively, of course, in theater, the patient will have had an echo done to look at the ventricular function at that time and also just make sure the anastomosis are all functioning well and there's no pericardial effusion post-transplant from that. Sometimes the patients return on ECMO where you have a primary graft dysfunction where they fail to of bypass, and they may need to have ECMO to support them for a brief period post-transplant and that. And subsequently, once the function picks up, they get wind of ECMO, and this usually done from PICU. They may come back to PICU with their chest open or closed. They may have a chest open because of a size mismatch, if there's quite a significant size mismatch, just to allow the heart to settle in and then close over the next few days. To avoid compressing the heart at that acute phase. They may also have some bleeding, which of course will be dealt with in theater at that time, but it depends on how significant with the drains and all. May also have the chest left open for a bit before it's subsequently closed when everything has settled. And of course, they return to PICU intubated and ventilated and with drains inside, 2 mediastinal and pleural drains. And of course, sedation on board with analgesia since they're intubated and then with the significant procedure they've just been through. Inotrope support continues at this time. So they come in on inotropes, vasopressors, just to support the hemodynamics of the patient and also to support the hemodynamics of the patient at that time as things settle. Sometimes they may come in with blood pressure concerns. They may be hypotensive if they've had quite significant bleeding and would come in also having blood products being given in theater and then also continued on PICU. Pacing wires will be inside to monitor the rhythm and rate of the heart post-transplant to keep that in. Epicardial pacing wires are usually used for them and then keep that in for quite a bit after transplant to keep monitoring. This also helps us to monitor for rejection, as well as other arrhythmias from electrolyte arrangements and all. Renal-wise, these are just the significant things that happen. Renal-wise, they may have had concerns pre-transplant. They may have had some renal dysfunction pre-transplant. So you'd also want to look at how the kidneys are picking up post-transplant. They've been on bypass, and they're back on just monitor kidney function with that. Some of our patients may also require renal replacement therapy. So they may need to have hemodialysis for some days to tie them over till their renal function normalizes over the next few days. And then we commence, of course, peri-transplant immunosuppression commences before transplant on the ward, just shortly before they move to theatre. They receive some immunosuppression, and then in theatre, they also receive immunosuppression. They receive steroids at the time of, just before moving cross clamp, they will receive steroids for that. And then once they return to PIC, they also have post transplant immunosuppression that will be started at that point, and then they would go on to be established on their immunosuppression. So these are the drugs we would use for the immunosuppression peri-transplant, both pre and then the immediate post-transplant period, and then continue. They would have surgical prophylaxis. They may have had infection concerns before the transplant, based on being long-term on a VAD and all other lines and having lines on for long. So they may have had infection concerns, and all this will determine what kind of antibiotics, what antibiotic regimen these patients are placed on post for the surgical prophylaxis. For straightforward cases, they would likely will just have prophylaxis for about 48 hours, and that will be stopped if there are no concerns. For patients who also have open chest for quite a few days longer, we may also look at the risk of them getting of infections with that, and then also either prolong their surgical prophylaxis for a few more days, or bring in other antimicrobials like antifungals as well if it's quite prolonged. And then anticoagulation will depend on if they came back on ECMO, if they had needed dialysis, if they've had stents put in, which usually maybe not usually in theatre, but a few days after due to some concerns with their anastomosis or their pulmonary blood flow. And then they may also have had vascular thrombosis, which either pre-transplant or even post-transplant, they may have that. So they could also be on anticoagulation for that. So as they continue, they're still on PICU for the first few days to week. They will be on PICU, needing quite a lot of support with that. And as they go along, usually straightforward respiratory support will begin to be weaned. Usually at about the second day post-transplant, for straightforward cases, they would have been extubated at that time onto non-invasive ventilation. Some may require support with CPAP or just with high flow. And subsequently move on to ventilating in air. Some patients who have had other concerns, pre or post-transplant respiratory concerns, may need a tracheostomy to move them along on their journey. And some may require bronchial stents as well. We've had patients who have had quite larger sized hearts transplanted with some compression of their the left bronchus. So we've had patients who've needed to have stents put in. And of course, drains as well will be removed at this time once a few days post-transplant, once there are no concerns of increasing drain losses. But hemodynamics continue to maintain that, to monitor that closely. Vasopressors and inotropes will gradually be weaned off as the blood pressure function on echo would allow for that. They would continue on some Milrinone for quite a while, awaiting, actually if they're going to end up with biopsies, continue on Milrinone for much longer while we wean off the other vasopressors and inotropes. And then we continue monitoring for acute rejection, because this is usually the early phase, higher risk of rejection occurring, and also monitoring for other post-operative complications like infection. So we will do this clinically, we'll monitor them, how they're responding, the observations, ECGs, echocardiogram. They would have serial echocardiograms. We do daily echoes for them, straightforward transplants with no other complications. In the first week, they'll be having daily echoes. I'll be looking at ventricular function and valves, and go on. So we'll just continue with that. While they're on PICU, for some of them who would need a biopsy, they may actually end up getting a cardiac with their first cardiac biopsy while on PIC. Blood pressure control is another thing that we're looking at. We monitor quite closely, and if they need to have antihypertensive, we would start them on that and continue with that. Pacing wires will remain in situ for some time, as I mentioned earlier, and then go on with that. For the renal function as well, we continue to look at their need for diuretics, their function, and continue with that. Then, sorry. And then continue to establish them on immunosuppression, as I mentioned earlier. So they would go on to have commencement of cyclosporine to establish them on that. And then they would have completed 24 hours of steroids at this time. I'll show the, just give a brief flash later of what we usually use for them, and then go on and continue. We'd also be able to start them on infection prophylaxis once they've started eating orally, even while on PICU, to continue with that. Electrolytes may need correction as well. Magnesium, potassium may need correction, supplementation as well, and we will start that and continue with that. Now, for the bloods that they would need to have done in the acute phase, in the early phase, we'll be monitoring their levels for the immunosuppression, renal function with the user needs, as really with the impact of these medications on the other organ systems. Look at CRP, monitor their liver function, bone profile, magnesium, and full blood count, just to keep an eye on the complications, development of complication, and also the impact of the next immunosuppression we've started. For patients who are ABO mismatched, we would need to do isohemagglutinin for them in the first week and monitor that daily to intervene with ATG. To intervene if we need to treat that if they develop any signs of increasing tightness and signs of rejection. We'd also monitor CD3 counts, and this is usually patients who have had ATG used at induction, and would monitor CD3 counts as well for the first 7 days post-transplant, and usually would have to give a repeat dose of ATG in them if their counts become greater than 0.05 at that time. Nutrition continues to be important even post-transplant. Initially, of course, immediate post-surgery nearby mouth on intravenous fluids, but then subsequently we'll begin to graded introduction of oral feeds, either by initially by NG and then work up gradually with volumes, and then go on to transit gradually till start tolerating enteral feeds over the next few days and build up on that gradually. Some patients may need a period of time on parenteral nutrition, especially with patients who have quite significant complications post-transplant, and that also is factored in. Sedation and analgesia will begin also to be weaned off at this time, continue to wean this off at this time as tolerated and as required. And physiotherapy, we usually commence physiotherapy quite early in the patients who are stable post-transplant. The physiotherapy team come in and then just start doing as what they can little as possible just to help with this patient's progress, mobilizing, just keep help them with breathing exercises just to help the lungs and to go on with that. Then we'll just come to medications that we would use at the time of transplant. We've seen a few of them highlighted earlier. And for immunosuppression, this is usually the combination that we would start with and use and then begin to add or take off or substitute as the patient goes along the journey. So for induction, either we're using ATG or Bevacizumab. And then for continue with the calcineurin inhibitors, cyclosporine. Usually we would use the IV cyclosporine in the immediate post-transplant period. And then as enteral feeds are established, absorption is more reliable, we would switch over to the oral cyclosporine and continue on from there. Some centers I know use IV tacrolimus, but here we use IV cyclosporine to start. Azathioprine or MMF are usually added within sometime a few days after transplant, so a week or so, when the patients have stabilized, blood cell counts are normal, liver function is normal, and we have no contraindications to starting that. So we may want to add on a second agent to the cyclosporine that they're on at that time. And then patients would have had steroid, as I showed earlier, they would have had steroids intra-op, and then post-transplant would have had IV methylprednisolone for 3 doses, 8 hourly. And usually for the older patients who would continue, the age group who would continue to have steroids, would then move them onto oral prednisolone, weaning doses, and then wean gradually. So these are the medications just to show pre-op. This is what we use routinely in our patients, and then intra-op they would receive that steroids, and then post-operatively we continue on these medications. And and then of course with prednisolone maintenance, as I mentioned, the protocol will differ depending on the age of the patient, and also if there are any episodes of rejection within this time. If there are episodes of injection within the acute period, we will go back to give them IV prednisolone and IV methylprednisolone, and then move on back to the oral. This is just to show for long-term suppression. This goes from within this first 30 days once they're established on their immunosuppression, and then beyond that when they've gone home as well. So we'll continue them usually on the calcineurin inhibitor like cyclosporin or tacrolimus, which we would change. Antonia, I think, will deal with that as we go along. And also sometimes we may add in azathioprine at this point, unless there are contraindications to these patients having them in this initial period. This is also it. Now, we have other medications, as we highlighted earlier, that still continue as they go along on ICU while recovering from transplant. And the infection prophylaxis would continue with acyclovir and cotrimoxazole, which they continue on for quite some while after transplant. Chlorhexidine mouthwash is quite important to help with that, preventing infections through the oral cavity. And then antihypertensive medications as needed, depending on if they're hypertensive. Diuretics will also continue for quite a while, and then we'll wean that off gradually to send them home on minimal diuretics as much as possible if there are no concerns with renal function and fluid overload. They would need, they usually would require some electrolyte replacement, magnesium commonly, and they are replace if there are deficits, and then just monitor them on magnesium, supplemental magnesium, and monitor levels for that as we do bloods. For patients who are more than 5 years old, they would eventually be started on pravastatin. We'll need to do a CK level prior to that, make sure it's within normal, and also can start them discharge if there are no concerns with that. And for the ones who have vascular thrombosis or stents, other things, they will need their anticoagulation continued up till the time of discharge. Monitoring so we continue to monitor, and we're looking more at the post-transplant complications, mainly at rejection, infection, and renal dysfunction within this early period post-transplant. So do that clinically, monitor with regular ECGs, looking for evidence of rhythm disorders, arrhythmias, and then echocardiogram, as I mentioned earlier, regular echoes initially daily, and then we continue to spread them out if there are no concerns. Paying particular attention to their ventricular function, valvular regurgitations, and development of any pericardial effusion. They will continue to have their routine bloods, as we had highlighted earlier, to monitor the levels and the other systems as well. And then HLAs would also be done in them. Usually we will do that at the end of the first week post-transplant, and then subsequently first month, and continue with the regime of 3 months, 6 months, and 12 months. If there are infection concerns, we would eventually have to do this a bit more frequently if there are rejection concerns with this patient, and monitor more closely. For cardiac biopsies, for the patients who are eligible to have this, suitable for cardiac biopsy, would also do this within the first, usually within the first 3 weeks post-transplant, they would have cardiac biopsies ranging between 1 to 2. And even if they develop rejection, then they would probably have a requirement for additional cardiac biopsies as we treat and then review their clinical course. Others I mentioned earlier, isohemagglutinin and ABO mismatch, CMV for CMV mismatch. And this just to show, just to run through cardiac biopsy. I'm sure Abbas will touch on that when he talks about rejection and complications. And I think practice here is just for the very young children, usually between 1 to 2 years, it's not routine to do transplants in them due to the risk of the procedure because of their small size and the risk to damaging structures in the process. Subsequently, for the children who are 15 to 20 kg, they would have one biopsy if there are no rejection concerns. And then the older, bigger children would have 2 biopsies within this first 3 weeks of post-transplant. So usually you do the first one within a week or 2 after transplant, and then the second one about a week later for them. And as we're monitoring for rejection, we know that the gold standard of for diagnosis of rejection is by biopsy. However, as we're doing serial echoes as well, this would help to also give us early, if there's suspicions of rejection from the echo findings, we will be able to decide if this patient actually is showing signs of rejection or not, and then move forward from there to manage them appropriately. So just things we look out for symptoms of rejection. They can be non-specific signs of infection or heart failure, and we're looking at that. So they could come with fever, tiredness, just feeling more lethargic and unwell. And of course, with the cardiac symptoms, shortness of breath, fluid retention. ECG would show arrhythmias, echo would show the echo changes with poor ventricular, reduction in the ventricular function, and then pericardial effusions can also be seen in patients with rejection. And treatment is with IV steroids once a day for 3 days, and then to continue them on high-dose oral steroids, and to continue to monitor closely and keep them under protective isolation during this period. So this is just to show the biotomes for cardiac biopsies that is used in the catalog. Just to run through the grading of acute rejection. So usually histologic diagnosis. So once we've had patient presents with features of rejection, has had biopsy done, this is the report that we would get back from the pathologist. So this is ISHLT grading for acute cellular rejection. That's the one on the left, my left, and goes from 0 to 3R, and while for the antibody-mediated rejection goes from 0 to 3. So you would see, I think in the discharge summaries would write ISHLT 0R, P, AMR 0, whatever it is that we found with that. So this is just the grading for that. So just coming to round up my presentation. So we've just gone through from what happens from return to theatre to PICU. Most of the early stage, the first few weeks are done on PICU, and then patients is stepped down to the ward to continue management, normalize the patient, and get them ready for discharge. So by this time, we expect that the patient, if there were no concerns, should have been weaned off respiratory support at this time, or even if they're still on respiratory support, will be quite minimal at this time. And then we can wean off on the ward and discontinue. Milrinone as well, some of them would have Milrinone stopped on PICU before they're stepped down if there are no concerns. Some may come downstairs, come to Ward 23 on Milrinone, and then we will monitor function, review, and then also wean that off, getting them ready for discharge. You have a second biopsy on the ward, as I mentioned earlier. Time, pacing wires would have been reviewed as appropriate and removed. And then for those who are on antihypertensive medications, would look at how their blood pressure control has been, and then decide if there are multiple agents we would want to reduce to the minimum so that they can go home on as little as possible. That would help to control their blood pressure. So would reduce the number, reduce the doses effective, just to try and just reduce the pill burden, medication burden as they go. Diuretics as well, be on some diuretics, and we'll be weaning gradually at this time, preparing for discharge. I mentioned earlier, for patients who have more than 5 years, they would have pravastatin instituted if there are no contraindications. And nutrition, continue to optimize nutrition to make sure they're in a good place with that. Change medications to oral medications where possible, and then also for the patients who will need long-term access to be able to do regular bloods, because they're going to be having quite frequent bloods even as outpatients while we're seeing in clinic. We would need to also decide what the best plan would be for long-term vascular access for them. Rehabilitation and physiotherapy continues on the ward. It's quite ramped up at this time as the patients are more mobilizing better, have had most of the concerns dealt with and settled at this time, and that continues. And then, of course, education of patients and family. Now, this starts from pre-transplant, even with the transplant assessment, continues all through the journey. And whilst these patients are on PICU, the transplant specialist nurses will have started some education with them, ramping it up as they go along, as the patient continues to improve. And by the time they get to the ward, I think they get to would have really done quite a lot with education based on medication and transplant, what they need to know about transplants, about living life outside the hospital with a heart transplant. So this starts quite early and then ramps up and continues and just keeps increasing. And then, of course, discharge planning. We have patients who most times have quite a number of comorbidities and have been seen by different specialties. So at this point, we're trying to bring everything together, know where we are with the different comorbidities they have and the other teams that are involved in their management, and put things together and just get them ready for home, so that by the time they get home, there's nothing that is missing in their care and everything is all arranged. Also liaise with the local teams as well to make sure that everything, all the patient support the patient needs locally is also available for this patient, and everybody's quite ready to receive them back. And of course, we can't overemphasize with continued vigilance. As per rejection, we'll continue to keep an eye out, look closely, monitor closely for that. So I think we've just gone through, from most of the medical point of view, what we look at once these patients are transplanted and start their journey post-transplant. Thank you. So I think we'll take questions after.
Antonia, if Antonia does hers, and then we can take questions at the end.
Thank you.
Okay, so I'm Antonia Philp. I'm one of the paediatric transplant specialist nurses here at the Freeman, and I'm going to talk about the nursing considerations regarding the first initial 30 days post-heart transplant. So we have a huge MDT that are involved in our care. There is more than this. This is just a little snapshot of it, really. We have the team will be involved at different points. And we have a MDT, which gets together every week to discuss the inpatients and make sure that the patient's care is coordinated as much as possible, as well as various issues being addressed. So what is the role of the transplant specialist nurse? So as I'm sure quite a lot of you are aware, there's a few of us. We support the patient and their family. We have the link for the PICU ward staff and doctors regarding all transplant issues and about blood levels and dosages of immunosuppression. We assess the families around their competency at giving medication administration and teaching. We liaise with the MDT to help support the family during the hospital admission. We communicate with and educate other healthcare professionals, teams, nurseries and schools. We lead the discharge planning and coordination of training of the family. We are responsible for ongoing training after discharge, and we provide telephone helpline post-discharge, which is very much used by our families. So I love this analogy. So Terry, who you all probably know, is one of our other transplant specialist nurses. He uses this analogy of transplant is not a straight road. There's lots of roundabouts, there's bumps, there's humps all along the way, and it is completely dependent on the patient. It depends how they've come into hospital, depends how sick they've been, kind of previous comorbidities, previous surgeries, the complexity of the transplant surgery and post-surgical complications, and that will very much determine the length of stay post-transplant. This is a particularly stressful time on PICU initially, with the most uncertainty. At this point, we therefore tend to avoid teaching, as we feel the parents have already got a lot on their plates and a lot to deal with, and they often struggle to retain information in this environment. The first biopsy tends to be carried out on PICU, and then they will tend to head down to the ward if everything looks okay. The transplant team work closely with the PICU team, ensuring that the patient is suitably immunosuppressed at this point. Then once they get to the point where they're looking a lot better, they are transferred down to the HTU or the ward, where they're put into a cubicle. During this period of time, we focus on the rehabilitation and the education of the families and the patient, dependent on age. We organise discharge planning meetings. We organise the home from home stay at Scott House pre-discharge. And the average length of stay in hospital is 4 to 6 weeks for our transplant patients post-transplant, but this can be a lot longer at times. So I'm briefly going to go back to the immunosuppressants. I know Yembi touched on it before, but just more from a nursing consideration perspective. So our immunosuppressants suppressants that we tend to use initially is cyclosporin. We use tacrolimus, sirolimus, azathioprine, MMF or mycophenolate mofetil, and prednisolone. So I just wanted to put a couple of pictures on because I know that you guys will probably see lots of different medicines, but this is some slightly blurry images of our cyclosporin. So it's the first line of immunosuppressant that we use post-transplant, as it's available intravenously. It's also slightly different in how we give it, because we give it over 4 hours, whereas IV tacrolimus is different. It's continuously administered. We give it IV until the patient is absorbing. And when the patient is converted to oral cyclosporin, the dose is always given twice a day, so 12 hours apart. We tend to say 8 and 8, but that just as long as it's 12 hours apart, that is good. The level should be taken as a trough, so i.e. before the next dose is given. When we give it via IV or NG cyclosporin, it must be given by a PVC-free giving set. And please note that it is not like for like the IV dose and the oral dose. So please ask us for any advice regarding that. Then we've got tacrolimus, so it is the second line if cyclosporin is not appropriate. Sometimes with our patients, we find that they bounce around quite a little bit with cyclosporin. There's also the side effects of cyclosporin, such as the gum overgrowth and also hairiness, which a lot of our families don't particularly like. Tacrolimus also comes in IV form, but that's like mentioned before, but our unit tends to not use IV. The dose is also given twice a day, 12 hours apart. We ask to always ensure the same brand is prescribed, ideally. Check for interactions and ask the ward pharmacist. Specialist manufacturers have different bioavailability. Generally, we use Prograf, which comes in different strengths. And we do have a couple of our patients who have problems with compliance or issues with their levels converted to Advograph. And for those who don't know, this is just given once a day in the morning. Then we have azathioprine. So generally all patients start on azathioprine post-transplant once tolerating their enteral diet. It works on the B cells and the T cells. It's classed as cytotoxic, so you have to be very careful around handling this. It's also available in oral suspension, 50 milligrams in 50 mils. If it is to be given via injection, it should be made up in pharmacy just due to its cytotoxic nature. And the tablet should not be crushed or halved, just use liquid instead. Then we have MMF. It's classed as an anti-metabolite, working by interfering with how white cells reproduce and function. Patients who are unable to tolerate azathioprine tend to use MMF. MMF is used in combination with other drugs in desensitization desensitization therapy for high HLAs. So if that is something that we're concerned about, we often start them on MMF. And there is a potential to be changed to myophotic, as that actually has some, is slightly more kind on their stomachs and help to reduce some side effects. We have sirolimus, so it's also classed as an immunosuppressant. It allows the reduction of cyclosporus or tacrolimus if patients have poor renal function. It's going to be later touched on around coronary allograft vasculopathy, but we use it if we have a patient who we know has coronary artery disease. It can help to prevent the worsening of this. We always give it in the morning. It should be stored in a fridge. Clearance may be reduced in poor renal function, and it's not given to with patients who are allergic to peanuts and soya. So steroids, so as Yembi's already touched on this briefly, we have different regimes depending upon the age of the child. Young children less than 5 don't get steroids routinely, as this can affect their growth. High dose of IV methylprednisolone is given as a treatment for rejection, and that's the 3 doses. It may change dependent on rejection and renal function, and it should always be given in the morning. And then antivirals are antibacterials. So we use 2. So we tend to use acyclovir, which is for prevention of viral infections. There's some doses there. And then we also use cotrimoxazole or cetrin, and that is for prevention of bacterial infections. And as Yembi mentioned before, we use the chlorhexidine mouthwash to prevent mouth infections. There's just a little bit about here. I think this is probably quite helpful for some of our liaison nurses throughout the country. So cyclosporin levels need to be taken pre the morning dose. It goes in an EDTA bottle. We ask the transplant team are informed if patient has any vomiting or diarrhea, or if any repeat dosages have been given. We ask that a level is not taken from a line that has had cyclosporin administered through it. So we often ask for families, well, for the PICU/ward nurses to not use the Hickman line for the administration of IV cyclosporin. We ask just for the test to be ordered just before the cyclosporin level is taken and not the evening before. And the tacrolimus level, it needs to be taken pre the morning dose and goes in the EDTA bottle as well. Again, to be informed if there's any vomiting or diarrhea. And then isolation. So patients should have limited contacts immediately post-transplant, as patients require protective isolation. This is initially because the immunosuppression doses will be a lot higher, so they are at higher risk of infection. When the doors are closed, if the parents are separated, they can actually bring a partner, bring their partner with them. So even though we only say parents allowed, we also say if they have separate partners, then they can bring them in as well. Once the door is open and the patient is allowed, parents and siblings plus 4 nominated family and friends can visit as well. And we have a full policy if anybody requires that. So rehabilitation is absolutely huge, and unfortunately I don't have a ton of time to talk about it, but this is probably one of the biggest parts post-transplant really that we look at. It will depend on a number of factors, such as how ill the patient was pre-transplant, deconditioning due to prolonged PICU stay, and factors such as dialysis, ECMO, or chest open. I think with this, with the rehabilitation, a huge part of it is the importance of speaking to the families about the whole family buying into the rehabilitation process to encourage the child to get moving as soon as possible. And they need to see this as a huge, significant part of the transplant journey. As rehabilitation, we could talk about the education of the patient and the family, the physiotherapy, occupational therapy involvement, any lines, feeding tubes, liaising closely with the dietitians to make sure that their calories are sufficient. Early discharge planning, phased discharge, and local teams are essential. So this is our lovely physiotherapy team at the Freeman. So
they've got a huge role really in the rehabilitation of our transplant patients. So initially, the plan with what they like to will have to do is initiate initial movement as soon as possible to get the new heart pumping. So this will be things such as moving in bed, sitting over the edge of bed, and then getting out of bed. As the new heart is classed as denervated, it means that the patient's body needs time to recognize hormonal changes to respond to exercise or stress, and the importance of warming up and cooling down. And then we ask, well, what was the patient's previous baseline? Had they been well on the waiting list for a transplant for a long time? How deconditioned was the patient prior to transplant? Also, we need to look at how sick the patient has been post-transplant, and have they been on ECMO dialysis. The physio team helped the patient to understand that feeling breathless is more of a general lack of fitness than an alarming thing that it was pre-transplant. And then next, how can they manage in their own environment? Can they get into their own house, to and off the toilet, into bed, off the floor, be age appropriate with dressing and daily activities of living? We want them to ensure that they can make the most of their life now they have a new functioning heart. And the team works really closely with the OT team here at the Freeman to ensure equipment is provided to do this effectively. And this is all looked at, so the patient as a whole, not just about their transplant. And then advice is given around appropriate exercise and activities, taking into consideration how far post-operatively they are, their bone healing and their recovery so far. So we try and make this journey as exciting as possible. We don't allow for any boredom. We have the play team and we have the clown doctors, which are these amazing guys here. We have daily activities planned, so all of our patients have a plan for the day. We do motivations through daily routines. We have things such as sticker charts, star charts, all of that to kind of motivate them to get up and do various things. We have the teachers, we have music groups, and we also have a playroom which can be booked out for the transplant patient and their family when allowed, and also a sensory room. And obviously a lot of these activities are kind of done from the door, or if the isolation has kind of come down, and they won't have such strict isolation. The social work job is huge, as I'm sure you can all imagine. They meet at the time of assessment. They identify any issues with housing and ability to keep up with mortgage payments / rental payments if the parent is not working for a while. Supporting letters for charitable funds, sibling support such as the Rainbow Trust, which helps sort out and also helps sorting out school places as families often temporarily relocate. We actually are having more and more of a problem with housing for a lot of our families, and also asylum, people who are seeking asylum. Is becoming more common with our population. Our social workers will also get in touch with employers and also psychological referrers and a friendly face. I think the psychological impact of transplantation is absolutely huge on these families. So initially, kind of early psychosocial needs, what is their previous history of the heart failure? How long have they lived with this disease for? Is it something that's quite new? Sudden onset, or were they congenital? Impact of shock and grief, initial psychological trauma care, relocation, disorientation. They're in the middle, they're in a completely different place. A lot of these families, they don't have the usual support systems, and they have practical issues such as finance, accommodation, other siblings, PR or safeguarding issues. And then after transplant psychosocial, so this is going to take some time to process, and they may have some PTSD off the back of what they've been through. And sometimes it's actually when they get home that they start to think about about the process, about what's happened to them as a family and their child. Parenting and resuming that normal life, and people probably not really fully understanding what they've been through when they've been in hospital. Picking up the pieces of life, e.g. work, siblings and friendships, living with this ongoing threat. As we talked about before, transplant is not classed as it's not a cure. Education, work, finances, travel, relationships, re-evaluating their goals and their beliefs. And this is just a few little bits of general information that you're more than welcome to take a screenshot of or whatever. just some general things, not having grapefruit, about isolation, when they can return to school, and they can do homeschooling beforehand. Just a quick one, we've got Scott House, which is our home from home. So as they've gone through that process and they're almost ready to go home, we allow the families to, the patient to go and stay with their family for a weekend before they're then discharged home after clinic. This is a great facility that we have, which is partially funded by our Children's Heart Unit Fund and the Sick Children's Trust. And then this is just a final little thing. So Claire, our VAD specialist nurse, showed a video of beautiful Grace, who was our longest patient on VAD. And for all of our patients, we like to clap them off now on the ward, which we kind of felt that actually, as I'm sure a lot of you are aware, that in oncology patients, they ring a bell when at the end of their treatment. And we felt that some of our families go through so much, if not more than some oncology patients. And I feel we felt as a team it was something really special to do. So I'll just share that with you now.
You're barred. Keep going.
Okay, and that's it. Thank you very much for listening, and please feel free to ask any questions in the Teams chat. Okay.
Thank you, Antonia. My camera's on again. Okay, I'll just while I fiddle on with this. Thank you. Can you stop sharing your screen there?
Sorry.
That's all right. There's no questions coming to the chat, Antonia. Can I just ask a question then about the Scott House transition? I'm sorry, I can't get my camera to come on right in a second. So obviously that's a fairly big transition for these families, especially if they've been on the journey for a year, 2 years in duration in the ward environment. Do the families reflect on that as being quite a daunting experience, quite a challenging experience, or do they feel that that's sort of a natural progression and they're ready for that by that point?
Yeah, good question. So I feel like it's, I mean, I guess it depends on the family, how confident they are with everything. But a lot of the time they've got to the point where they feel ready for that step in the journey. Yeah. And the Scott House is brilliant because it's on site. So they're really, really, really close to the ward. So if they've got any queries, if they need to get their child back to the ward as quickly as possible, it'll take literally like maybe 7 minutes or something for them to walk across. And it just gives them that little bit of confidence. It's the step in between. It makes sure that they feel like they're okay with everything, so that when they then come back into clinic on the Monday after the weekend, they can then ask us if there's anything in particular that they've been worried about whilst they've been there. So it's a really lovely kind of thing that we can do for these families.
Yeah. And they manage the medications when they're over there, or do they come back to the ward for that? How does that regime work?
So they manage the medications. We would just ring them like we would with any dose changes if there's been any levels done kind of during that time that they've been there.
So very much mimicking what it's going to be like to live at home independently.
Exactly.
But close to the team. Yeah, great service. Well, there isn't any questions come in, but I do have the whirly blue circle of doom again, so it's no doubt going to kick me out again. Sorry about that. But while I still have some sort of functionality, can I introduce Dr. Abbas Kushner to the session? Thank you, Antonia.
Okay, I'm just going to share this.
I'm going to log off and log back on again once I get this.
Can you see the screen?
I can't see anything. Could somebody else just let Abbas know if it's on?
Yeah, we're good.
Yeah, brilliant. We've got some thumbs. Thank you.
Thank you, everyone, and thank you for joining in today. It's been a great attendance from across the country, and we've had some excellent talks so far. I'm Abbas Kushner, one of the consultants here, and we've got a great transplant team receiving referrals across the country, and I've had the chance to meet a lot of people and also speak to a lot of team members across. I'm going to talk a bit about the complications and the long-term outcomes. So we've really set the scene quite nicely in terms of getting a bit of a background about the transplant journey, the history of transplantation, and both Yambi and Antonia finished off with the first 30 days that you come across after a heart transplantation. And some of the long-term outcomes and the complications are reflective of what you've just heard from them in terms of the complications that you look into, but it's more about the surveillance and picking them up at the right time and as they move across the journey in the years to come. So this cartoon just gives you an idea of how a heart can look before transplantation and post-transplantation when you've got a donor heart, in terms of just looking at eyeballing it, how diseased or how worn out the old heart is here. I don't have any disclosures for this talk, and the format of the talk is going to be along the lines of just taking you through a bit of the post-transplant course, talk about survival and complications, and bring them down into sort of cardiac and non-cardiac things that we look for in our patients. Complete off with some compliance and transition challenges that we come across. And I think there's much more discussion on that later during the day. And also talk a bit about retransplantation as part of these complications that can bring along. So you've been through the post-transplant, sort of through the transplant journey, and in a very simplistic form, if I just put it in one slide, you've got 3 real phases. You've got the pre-transplant, where we do the assessment. Most of our patients, fortunately, are planned assessments, but you could have patients who are acutely unwell, and there's not much time for the families to go through the actual transplant journey, and things are just sort of happen very quickly for them. Once the transplant assessment process is completed and the patient is deemed suitable for transplantation, they either go on a waiting list for transplantation, or if their heart is failing significantly, then we have to use mechanical circulatory support as a ventricular assist device to bridge them while they're waiting for a heart transplant to happen. And Claire spoke to you about the mechanical support journey for these patients. And then comes the important aspect of post-transplant. So while pre-transplant and transplantation itself has got its challenges, the more important aspect then becomes is you want to survive that graft and keep it going for as long as possible so that the patient and the families don't have to go through any of this journey again in the future. And so you look at the immediate post-transplant period, which we've just alluded to, about 30 days. And then as you go towards discharge, you start looking and following patients in clinics, regular surveillance, communication with the families. And then when they come to about 18 years of age, look into transition as part of that journey. Here is a picture of one of our patients who is from Scotland, and he's doing really great. He was a DCD heart transplant, so he had a donor from circulatory death rather than the conventional DBD. So I thought I'll bring up his picture. And then here we got a young man who unfortunately is not with us anymore, and he's been through the transplant journey for a period of time, and this is before his last few days of passing away. So it just gives you an idea that patients can be very well initially, but things can just drop off, and that's why surveillance becomes quite important for us to carry on as they move through that journey. So once you've got the transplant, the clock starts ticking, and then there is no looking back. And the important thing is to make sure that the heart remains healthy and the graft survives as long as possible. And in the current day and age, with the immunosuppression and the type of care we have and the surveillance, an average heart would last between 15 and 20 years. And we try and bring that into active completion so that patients don't need a further heart transplant in the coming time. This picture has already been shown today. This is a little baby in the 80s who got transplanted now in her late 30s. And it just gives you how a journey from start to finish can end up. There are other patients who might not make it through this long journey, and it's important to have a reflection on how you survive them. So when you look at survival for heart transplants, in my presentation, there will be some graphs and some sort of data, but just to give you a bit of a landscape of where these things that we look for are important and how we try and maintain the survival for these patients. So in the first year, as you look at the graph, this is from ISHLT from 2018 data, but it pretty much holds true today. And you can see that in the first year, most of them survive up to 90 to 95%, and there's very little. So we are very acute and very good in managing patients with survival, and many of them survive excellently in today's day. But you can see that as you move forward into 5-year survival, things start dropping off. And as you can see, the blue is the overall survival, but then you can see the different graphs within the first year to till they are 18 years of age. And as you get older, the survival starts becoming much challenging. And by 10 years, at least 70% of our patients will survive the first graft without problems. And this is, again, important because it emphasizes the fact that the surveillance is quite important, and picking up complications early and managing them well allows that to happen. And most importantly, the quality of life for these patients is important. So while you're trying to survive the graft, you also need to maintain the quality of life, that they want less hospital admissions and less treatments done to them, which they previously had with their heart failure, and you want to try and reduce that if you can. So it's all about long-term future for these patients rather than just the short-term outcome. And with survival comes the risk of complications. And they go hand in hand, because if you are able to avoid complications, your survival gets better, and vice versa. Both Yembi and Antonio have highlighted some of the complications in the early post-transplant phase, and they sort of carry on in the long journey as well. So you can see a graph where the first green one is the graft failure, and then you've got the yellow line, which is the acute rejection. So in the first 30 days of the first sort of year, the chances of rejection are high, but if you manage the patients well, then you will not see an issue there. And then as you go throughout the 10-year period, that graph slightly starts going, and the percentage of deaths become a bit less. But at the same time, if you see the coronary vasculopathy, which is the coronary artery disease, that is initially very low, so you don't have that complication in the first year or two. But then as you get towards the 10-year mark, that risk of complication increases. And this graph gives you a good idea of how you would look at different complications with the journey of the transplant type. So when you have a child who is 5 years post-transplant and we are not sure whether it's rejection or whether it's coronary artery disease or infection, then you start looking at what could be the reason for one of these to happen. And obviously, this timeline gives you a better idea of what's likely to happen in the graft's journey. So we'll start off with rejection, and rejection is one of the main things, and because it can be very acute, and if you've not picked it up on time, it can be quite a devastating outcome for the patient. And while the other complications or the other sequelae of transplantation might take its time to show itself and even have the impact on the child, rejection itself can be quite acute in that sense that it can really cause the death of the child if it's not treated in the appropriate timeline. You can have chronic rejection where this is related to the antibodies and the graft failure happening over time. And because your body is constantly trying to reject this organ, which is not theirs. And as a result of that, you start having chronic rejection, but that you see as a more slower process. And it's something you really can't do much about it as long as you don't lead to an acute rejection on top of that chronic episode that is ongoing. So in terms of clinical signs, we'll come through that a bit later on again. You look for clinical picture of rejection, which would be tiredness, fever, arrhythmia, collapse. You've got imaging, which allows you to look at various aspects of your echocardiogram. So if your function is falling off, if you see effusions, then that gives you an idea. Now, sometimes that's not possible if you are in a peripheral center or a local hospital, and you have to rely more on the history at the time of presentation, and then subsequently move that child to a cardiology center close by, or then move to ourselves at the Freeman Hospital for further assessment. We also look at the antibody trend. So this is something which can be part of acute rejection, but also chronic rejection, where the antibodies in the recipient start increasing in number. And we've talked about monitoring antibodies regularly in the previous talk, and that is quite an important aspect because they will sort of hit the graft from sort of the background and keep causing a bit of graft failure. You can do different types of imaging. So different hospitals, transplant units have different imaging modalities. Certainly in North America, they use a lot of biomarkers for looking for early signs of rejection through blood tests. There are other imaging techniques as well, which are used to allow you to look for rejection. So this is just a slide to show you the histopathology. So when you take a biopsy sample, which Yembi alluded earlier to, it gives you an idea of whether the heart is rejecting or not. And this is just an echocardiogram showing a 4-chamber view of a patient where the graft is not working very well and it's not contracting very well. It's very bouncy and gives you an idea that this heart is not great in terms of its function. And then it should ring alarm bells if you see a heart like that in terms of worrying about rejection. So biopsy is one of the gold standards that we use. But again, biopsy is not the answer to all the rejection episodes because there's 20 to 25% chances that the biopsy might not pick up because the biopsy is as good as the sample that's taken on from the heart. So sometimes you've got the heart tissue which is picked up and doesn't demonstrate, you could really miss on. And certainly in the UK, given the way patients present and the geography that we have and the pediatric patients which would require a general anesthetic to get a biopsy, we tend to allude more towards just treating the patient if you're worried about rejection rather than getting a biopsy. So probably 8 out of 10 times, if we have a clinical history and echocardiographic confirmation that this patient is likely to have a rejection episode, we would just go ahead and treat that patient without waiting to do a biopsy. The other thing with the biopsy is it also takes about 24 to 48 hours to get the results. So you don't want to wait for another 2 days before you start treating the patient with rejection with steroids and so forth. And it's important that the treatment is provided imminently. So this graph, again, taken from ISHLT, which is the International Society of Heart and Lung Transplant. And this sort of is a cumulative data from international centers across the world, which submit into the ISHLT. So most of the graphs that we'll be showing you are from the ISHLT, and they give you a more international perspective of transplantation and complications related to it. So if you can see the blue line here, it just gives you an idea of a patient who's free of rejection. And you can see the survival line is much higher. And if you have been treated with rejection in the first year of life, it starts dropping significantly. And by 10 years, you can see a huge gap between the patient who has not had a rejection episode compared to the one with rejection. So it just gives you an idea of ensuring that it's not about just treating acute rejection and getting the patient out of that rejection episode, but it's also about long-term survival for that patient. So it's quite important to timely identify rejection as one of the acute problems and then treat it imminently. So here is a patient, just to give you an idea, who had an echocardiogram in our clinic, and then 3 months down the line, just came for a follow-up visit, suddenly the echocardiogram. So again, for those who have not seen echocardiograms or looked at images from echo, it's a 4-chamber view of the heart with the two upper chambers are the atrium, and this is the ventricle. We're really focusing on the left ventricle, which is what we worry about in graft rejection. And this is a well contracting ventricle, but here you can see it's hardly moving with little twitch like movements only. And this patient came in after 3 months, and suddenly the graft started to show signs of rejection. So you might be complacent in thinking that the patient is completely well 3 months ago, and suddenly it's all changed. So any form of surveillance is as good as you pick it up on time to make sure. And this is after the patient was treated and is almost back to pre-transplant after 6 months of treatment. So it just gives you an idea that this is a patient who was 6 years post-transplant, that had an episode of rejection, and post-treatment is pretty much back. But obviously now this patient, having had an acute episode of rejection, the survival of that graft is relatively less than if the patient did not have rejection. The next thing to talk about is infection. And I thought I'll just go through all the complications before having a chance to take on questions about each area, because it's a large topic to discuss in a short period of time. It would be best to just go through some of the complications first, and then we can pause to take some questions in the end. So infection is, without surprise, you are immunosuppressed, you are likely to get infections. Children, as you know, if it's a 1-year-old or a 2-year-old without a heart transplant, is also more likely to get a viral infection, even with a healthy heart. So if you're on immunosuppressions, that magnifies for smaller children. But at the same time, even if you're older, the risk of infections is much higher. And as Antonia and EMB alluded, you treat them with prophylactic antibiotics and antivirals to avoid those episodes, but also not to try and treat them blindly, because if you have an active infection ongoing, you need to ensure that you give the right treatment so that there's chances of treating them in the future rather than making them resistant to it. And I took this from a paper which is a bit old now, from 2007, but it just gives you the breadth of different infections that can happen in children and older patients. And it just gives you a bit of an idea of the acute or severe infections and more chronic and recurrent infections. So this is just from one paper. There's lots of other different infections that come through, but it just gives you an idea of the breadth of things that can happen in the journey of a post-transplant period. And I think that that's important, because when we manage patients on immunosuppression medications, we are very wary of the fact that if you treat them highly with immunosuppressions, you increase the risk of infection, and vice versa. So it's a very sort of critical balance of making sure you give enough immunosuppression to allow the graft not to have a rejection. At the same time, you don't want to make them too suppressed to cause them to have an infection. The third one is called coronary allograft vasculopathy, or CAV, and that is to do with where the coronary artery disease kicks in. And I showed you the graph where coronary artery disease starts happening much later in the journey of the graft life. So the first few years are relatively safe, and this chronically gets affected because of releases of different inflammatory cytokines. So it's more technical in that sense. But what ends up happening is that there's damage to the wall of the coronary arteries. And here you can see a cartoon where the coronary arteries look normal, and then gradually they're starting to get areas of stenosis or narrowing. And the other thing you see relative to what you don't see in myocardial infarction or heart attack in adults, where again you have narrowing or blockage of the vessels, is called pruning, where the blood vessels just become thin and small as they go distally from the origin of the coronary arteries. So that means that the amount of blood going to the heart itself starts getting less and less with time, and the heart becomes hyperperfused, and the function of the graft function also starts becoming affected as a result of it. So that is something which we can't do anything about in terms of stopping the process. What we can do is try and minimize the episode and the frequency of that coronary allograft vasculopathy. So some of the factors that causes CAV could be pre-transplant. So it's to do with the donor size and age. So if the donor has some risk factors in terms of age or risk factors pre-transplant, that could be taken on by the recipient as well. If there's been a brain death or anoxia episode prior to the donor giving up their heart, that have impacted the heart muscle and the coronary arteries in one way or the other. And then risk factors like smoking could also be a contributory factor to coronary artery disease, as we all know. And then certainly post-transplant, we try and avoid episodes of rejection. So once you have an episode of rejection, that leads to cellular death of the whole heart, and that in turn damages the coronary arteries as well. Factors like high levels of cholesterol or lipids can also be contributory, and that's the reason we use statins in all our patients. And then infection or reinfection with viruses like CMV or cytomegalovirus can also be a contributory factor. So I think it's more about trying and preventing the progression or the onset of CAV rather than trying to treat it once it happens, as opposed to treating rejection and infection where you can treat the problem. Here you have to try and prevent it from progressing. And the ways you can do that is, this is just a cartoon again showing you the cardiac allograft. So here you can see the heart with the coronary arteries. This is a healthy looking coronary artery. And as you see that CAV starts happening, the wall of the coronary artery starts to get thicker. There's a lot of fibrosis around the vessel wall. And you can see that the lumen of the vessel wall is getting much smaller as the disease progresses. And this in turn leads to hypoperfusion. And this is something you can't just treat by unblocking it. So if you had a block in just one part of the blood vessel, you can use stents straight away. But if you've got the whole vessel, which has become narrow as it is here, you can't do anything about it. So it's more challenging to manage this. The way we do surveillance is we look for by imaging modalities. At our unit, we use coronary CT angiograms to try and avoid doing a catheter or an invasive intervention. And so CTs are used in all children who are older and will allow us to do a cardiac CT. We do coronary CTs, and they will allow us to, on an annual basis, see what the coronary artery anatomy is or whether there is evidence. Children who are younger and are not able to have a non-general anesthetic CT will undergo through a standard catheter coronary angiogram, and then that will allow us to look at that. But obviously getting a general anesthetic and an angiogram is more challenging with the bed availability and so forth. So we quite try and get these patients through CT if possible. There are other ways of surveillance as well in terms of ultrasounds. It's called intravascular ultrasound or IVUS. We don't use that in our center, but our other center, Great Ormond Street, they use that as part of the surveillance. But I think in essence, the idea is to try and pick up the disease and then manage it once you identify that there's evidence of CAV. Children will not get much symptoms or pain like chest pain related to angina because of the coronary artery disease, because of the sympathetic nervous system has been disconnected at the time of transplant. So again, it's a bit of a silent disease. You don't really pick it up by symptoms or signs, and it's something you will just have to identify by surveillance and monitoring of the graft and the coronary arteries themselves. So as you can see in this graft again, freedom from coronary artery allograft vasculopathy. If you've got that, then that allows you to stay quite well. But the moment you start having the disease, it starts falling quite a bit, especially if you go to the 15 to 20 year mark. So just prevention treatment, make sure your immunosuppression is optimized. We tend to use sirolimus as the medication for CAV. So we change them over from tacrolimus or cyclosporin, depending on what the primary immunosuppression medication is, to sirolimus, which allows us better protection of the endothelium of the blood vessels and slow the progress of the disease. As I mentioned, statins are used as preventative, and that's used in adults as well to prevent coronary vascular disease. And we tend to use our percutaneous coronary interventional colleagues if you have focal narrowing of the vessel, which is amenable to putting stents or ballooning, and we try and improve the coronary artery disease by doing that. And eventually, if the graft is completely failing with no other option, we might have to consider retransplantation as the only other way of getting rid of this problem. I'll briefly touch about a couple of things which are less common, but again, part of the long-term surveillance. And one of them is post-transplant lymphoproliferative disorder, a very long term, but in short, we call it as PTLD. Essentially, it's a malignancy through the lymphatic system because of abnormal proliferation of the lymphatic tissue. And it's a bit of trying to induce cancer by reducing the immunity and allowing those cells to grow very fast, like the cancer cells do. And this is as a result of using immunosuppression. And the immunosuppression causes these cells to grow very quickly and starts forming nodules or cancer cells within the body, often seen in the chest area, but it can spread across various parts of the body as well. And some of that is driven through EBV. So EBV is a type of virus. It's called Epstein-Barr virus. And as you have your immunosuppression, the levels of EBV can rise. And because it's a virus which is sort of dormant normally, but with immunosuppression, it gets a chance to increase in number within the body. And that sort of is a precursor or triggers the risk of PTLD in our post-transplant patients. Obviously, once you've got a malignancy, then the treatment of malignancy is run with our immuno-oncology team, and they manage the treatment of the disease like any other cancer patient would require. So one of the things that we can do from our end is to try and reduce the immunosuppression, so bring it down to as minimum as possible so that the process of lymphoproliferation is reduced. Keep on monitoring the graft function, so you don't want to take your eyes away from the heart itself to ensure that there's no other reasons for the patient to have a complication as a result of it. And then from a PTLD perspective, as I mentioned, it's either chemotherapy or using immunoglobulins and immunomodulation therapy. So we use rituximab to help treat that as part of the treatment for PTLD. We've had quite a few patients with PTLD, and they have done reasonably well over the years, and they have been able to survive the journey alongside their graft, and they've done reasonably well. But it requires more constant surveillance, making sure that your immunosuppression therapy is on the lower end. So this is just a graph again to give you an idea of freedom from malignancy and how you would be as compared to. So the blue one is for all other malignancies. The pink one is the lymphoma. So obviously all these complications then reduce the rate of survival, and that is the important factor. So you're not, the complications are not going to kill the patient, but obviously reduces the survival of the graft and the life of that patient, certainly. And then I'll talk about some non-cardiac complications like kidney dysfunction. And it's something which we see quite frequently in our patients. Certainly now that we've get more patients with congenital heart disease who have had constant comorbidities and issues with your sort of renal perfusion, that leads to severe complications in terms of renal dysfunction post-transplant. And it just gives you an idea that sometimes you also require a combined heart-lung transplant in patients as part of it. Though we don't do that here that frequently, given the donor availability. This is, again, most of the data is from from North America, especially the US, where the availability of donors is much easier. So if you have a kidney which is very suboptimal pre-heart transplant, certainly a combined heart and lung transplant would be a better option to do, but certainly you need to have enough donors to be able to facilitate that. And the efforts would be tried to have a combined transplant alongside. Often in our scenario, a lot of our patients end up getting a heart transplant, and we try and optimize the kidney function subsequently. And we've had a few patients who required renal transplant subsequent to the heart transplant as a result of not being able to survive those kidneys. One other thing which is quite important and something which even the local centers can manage is post-transplant hypertension. So we see in a lot of patients get immediately post-transplant can have high blood pressure, but also in the long term, blood pressure can be an area which needs to be addressed. Now, we all know hypertension in itself is an increased cardiovascular morbidity. So in a patient who has had a heart transplant, it certainly need to ensure that they have good control of their blood pressure to prevent high episodes of hypertension. If you look at the adult literature and generally some of the pediatric literature, up to 90% of the patients post-transplant will have some degree of hypertension, both in the first 30 days or even the first year of life post-transplant, but subsequently a lot of them would have hypertension which requires treatment even in the longer term. And certainly higher risk of morbidity from a cardiovascular perspective will also lead to graft dysfunction over time, and that will add to the reduction in the survival rate for these patients. And some of the reasons for hypertension in the post-transplant patients is ventricular hypertrophy. So when you get a heart from a donor and it goes to a recipient, there is a time where the heart is transferred from the donor to the recipient time. And during that time, the heart goes through a phase of becoming hypertrophic to sustain its potency, and that hypertrophy remains even when the heart is then attached to the recipient. Also, there is a size difference. So often the heart is around 2 to 2.5 times. The donor is almost 2 to 2.5 times bigger than the recipient in terms of the size. And that means that you're getting a bigger heart in a smaller child, and that in itself leads to more cardiac output and chances of hypertension. And then there are other causes like arterial stiffness, sympathetic denervation, where your heart will be disconnected from the nervous system. So there is no way of knowing whether the heart needs to beat faster or slower. And there's a constant static plateaued heart rate in most of these patients. And that can also give a rise to your blood pressure. Graft vascular disease, complications like rejection, and certainly kidney function in itself can also lead to hypertension as a result of nephrotoxicity. We use several different types of medications for treatment. The most commonly used is a calcium channel blocker like amlodipine. We try and avoid using ACE inhibitor like enalapril, which can again affect the kidneys, which are already a bit fragile, but it's something we end up using if we require, and one therapy is not enough for these patients. Other medications we can use like direct vasodilators like hydralazine, alpha blockers like prazosin, and rarely beta blockers, again, because of the sympathetic denervation. Beta blockers don't have as much impact on post-transplant hearts, but if we need to sometimes use them for rate control, we do give that a try as well. Another thing we see less frequently, but is also there, is the post-transplant diabetes. So sugars can also be an area where you might have to deal with in the post-transplant journey. So sometimes pre-transplant morbidity like chronic heart failure could have damaged their pancreas, could have caused a degree of diabetes. Again, with the complexity of patients we get with congenital heart disease and so forth, chronic heart failure could be a predisposing factor for high sugars. Post-transplant, depending on how the transplant itself has gone, we've had patients where there's pancreatic injury and where that has resulted into damage to their organs, which then causes diabetes or high sugars as a part of it. Anti-rejection medications, so if you don't have any of the two, then anti-rejection medications can also lead to hyperglycemia, and the sugars can be high and they might need treating. Usually by 3 to 6 months, you start seeing if it's only related to the medication, things stabilize and they come off their treatment for diabetes at that point. But it's something that is there to look for as we go. And we do check their sugar levels on every clinic then when they come in for review. Certainly the main thing from our point of view is that if you have diabetes or raised sugars, then that is another increased risk for infection, further damage to the renal dysfunction, which is already there. Diabetes, as you all know, leads to microvascular disease, which eventually will also worsen your graft disease. And then you also have to be mindful of the long-term complications of diabetes. So it's not very often that we get patients, especially in pediatrics, to worry about, but it's something which we have to keep our heads on for post-transplant surveillance. Then I'll move on to some other areas of surveillance, which is more for the long-term outcomes perspective. So I think psychology and well-being has been already touched upon in the previous talks, and it's an important element that we constantly keep an eye on and talk to families. And it's important to note that transplant is just not about the patient, it's also about their families, which go through the whole journey, certainly the pediatric heart transplant population, and it's just not the patient. So the psychological and well-being, mental well-being of these patients is as important as the families that look after them. And there's various triggers that can lead to psychological trauma or stress. Emotional to begin with. So obviously you get your highs and lows pre-transplant, post-transplant. And as we've had in the previous talks, the journey for going through pre-transplant through a mechanical support strategy to a post-transplant in itself can be so prolonged that the patient's journey will involve so much emotional highs and lows. There will be time where we might say that the patient is not suitable for transplant, and then again they are suitable. So it's a constant up and down journey for these patients. Certainly the smaller children will not understand that, and the parents actually go through that, but the older children will also be part of that conversation and already subject to that. And then there are the stress and challenges which will come with multiple medications that they have to have post-transplant, the surveillance and talking about complications, which I've just alluded to right now. And obviously that will have an impact on the child and the family moving forward. And then for the child itself, as the patients grow, so we've got kids who are 1 or 2 years of age when they get transplant, and we follow them up till they are 18. So they go through a growth spurt, they go through physical changes, mental changes, environmental, and even simple things like just having the scar on the chest with multiple scars on the chest drain sites and things like that can become a challenge for that patient for their mental well-being in terms of how they look and how they are going to grow up with their peers and friends. And then you could actually have psychiatric problems in terms of anxiety, depression, behavioral. A lot of patients have autistic spectrum disorder that we have to deal with, and that is part of the ongoing assessment that we go through. This is a paper we just gives a bit of a snapshot of how transplant events happen at evaluation of transplant journey, 1 year at post-transplant, and between 5 to 10 years. And it just alludes to the medical issues and then compares it with the psychological issues that can come along with it. And there's so many things that you could do in terms of, and I think the key message from that is you need to provide the counseling and the right support groups for all of these patients to be able to take them through the transplant journey moving forward. Adherence and compliance. So as we come to our kids who get older and bigger, taking medication can be a problem. So if they're going out with their friends and they want to party in the evening, they might not want to take their tacrolimus, they might not want to take their cyclosporin. And I think it becomes quite important to emphasize that. And it's one of the worrying things for us, especially as we see teenagers coming through and suddenly we get their levels coming and one level is quite high, the other level is completely low. And we clearly know that the patient isn't taking the medications routinely and on time. And that is a big worry because as you can see in the graphs in the past, the graft rejection episode starts getting worse and your freedom of survival starts to get worse as things get worse in terms of not being compliant for medication. And as the graft is getting older, it's more important to make sure that they don't get rejected because it's already started to have episodes of graft failure. And that would lead to things like retransplantation. So this is just a slide from ISHLT again, the amount of retransplantation. And though there are ups and downs, you can see that internationally from 1994 to 2016, the number of retransplantations have been pretty consistent and required in a lot of our patient populations. But certainly it comes with a caveat that if you've had a primary transplant and retransplant, again, your survival starts to decline. And you can see the blue line, which is the primary graft, and the brown line, which is the retransplantation. And you can see as the graft life gets older, the chances of survival reduces in the retransplant cohort of the patient population. And finally, I'm just going to touch about transition. I know there's going to be some talk about it later after lunch as well. And I think transition in itself is a new challenge, and it is a balancing act because as the adolescent is going to be an adult taking their own decisions, it's trying to cross that bridge without having to worry to fall off and having to come off that bridge on the other end without any problems. So I think it's quite important to look at transition challenges. And I've just got one slide to talk about that. And I think the transition challenges start with having been part of the pediatric transplant team, and we are all subject to this. We are unable to give our patients because of the long extended relation that we have, and which is a good thing. But as it comes towards the end of that 18 years of age or 19 years when they're ready to transition, it becomes quite challenging, not only for the patients, but also for the families who've been with us for such a long period of time. And then the other side of the story is where the adult transplant team comes, who is very much less experience in managing old pediatric transplant patients. So you've got patients who come in with 10 years or 15 years of transplant journey as a pediatric patient and suddenly going into an adult with very little experience of dealing with it. The adults are good when they do the transplant and they know they've started the ball rolling from day one, but it becomes more challenging for them if they're going to take something which is 10, 15 years old and manage very differently in pediatrics as opposed to adults. And that brings its own challenges. Parent issues. So there's a lot of interdependence and overprotection sometimes that parents go through, and then letting go of that is again quite difficult to understand. And then the adult himself, the young adults, some of them are very much dependent on the parents. Till they're 18, they don't even know all their medications, and the others are very savvy and they start picking up things even when they're much younger. And then there's also issues around the development and chronological age development versus their physical development as a person and how they can cope with those things. And then other issues like Antonio highlighted, financial, employment, education, living independently, relationships, all that would come into this when you're looking at transition as part of it. So I'm going to finish off by, so this is just a slide to say that we have started using a stage approach where we start transition much earlier than required so that patients start getting a bit of an understanding from that. So I'm going to finish off with this last slide with a few examples of how patients turn up with any of these different complications at your unit before we tend to see them, or you could raise a red flag to say that we are worried about this patient. So one scenario would be related to rejection, that patient might just present with reduced appetite, shortness of breath, fluid overload, weight gain, and lethargy. And this is all in the context of a post-transplant patient coming to your unit. There might be another patient where might not have all the symptoms, but when you bring them to your investigation unit, you might do a chest X-ray and that shows lung congestion or effusions. If you do an ECG, it might show arrhythmias, such like heart block. And that would be a bit of a red flag to say, yes, we're worried about this patient, and let's just pick up the phone and speak to the transplant unit to see what they think about it. And then infection can kick in as a slightly different. So you might not have rejection, but patients might present with temperature, fever, weight loss, GI symptoms, and that could be related to infection, and that might need treating. And we've had patients who've got significant EBV viremia, which has led to actually the patient not surviving the journey and has died as a result of it. So the EBV then can escalate into multi-system organ involvement, and that could be quite detrimental for the patient. It happens very rarely, but it's something we have to keep in mind. Then you might have graft failure, which could be just chronic graft failure, which is a bit like heart failure in a primary heart without a transplant. And then you might see signs of a low cardiac output or heart failure. So you can get hypertension, heart rate going quite high, generalized edema or hepatomegaly, and then that might suggest that the patient has got graft failure. And finally, if you're not sure of any of these above clinical features, it could just be related to adherence, non-compliance, and something that's just not normal for this patient. Might warrant you to just pick up the phone and check whether the patient is doing okay or not. So that's me done, and thank you for listening, and I'm happy to take any questions, and hopefully I just kept to time, 45 minutes. Thank you.
Absolutely perfect on time. Speaking at 100 miles an hour, that was brilliant, Abbas. Thank you so much.
Sorry, I just covered so much in that. So
no, that was excellent. Absolute whistle stop tour through a turbulent journey there. There aren't any questions popped in. Oh, hang on a moment. One question for you, Abbas, before we break for lunch. Can you explain the significance of CMV mismatch, please?
Yeah, so the mismatch brings its own challenges in terms of whether the patient is then going to likely get a CMV infection or the number of antibodies that are going to go up. So if you have a CMV mismatch, so if the patient did not have CMV, but the donor had CMV in their bloods before or vice versa, then we just have to monitor them with more vigilance and surveillance to ensure that infection from CMV is not a concern. From a CMV perspective, if we do monitor them slightly different to the other center, and then if we feel that there's a CMV mismatch and we look at the levels of the CMV titers, which is a PCR, that will give you an idea whether the patient needs to be treated with antivirals at 4 weeks of post-transplant period.
Thank you very much for that. We can discuss that further towards the end of the day if you need any more information around that, Hannah. Okay, break for lunch. We will be back ready to resume at 1 o'clock, please, everybody. So enjoy your lunch and your break, and we'll see you back here then. Thanks a lot. Take care.
Well done.
Oh.